afternoon from Thailand and welcome India panelists to be joining very important session today of how we could handle COVID-19 management crisis of India and lesson learned to Thailand. And this is very important discussion because we are now facing crisis of COVID-19 pandemic all over the world, especially the significance of the situation in India. It would be very valuable to learn directly from experts from India who are doing this great work frontline. And before I proceed to the whole tradition of the whole session of panel discussion, I would like to start by following India custom of deliberation by lighting a lamp called Diya in India. Diya signifies purity and divinity, dispelling darkness so that we can illuminate our minds with new knowledge. And this is very beautiful custom. And then we'll be following by national anthems from India and Thailand.
जनगणमन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मागे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हेประเทศไทยรวมเนื้อชาติไทยเป็นประชารัฐผ้าไทยของไทยทุกส่วนอยู่ดำรงคงไว้ได้ทั้งมวลด้วยไทยล้วนหมายรักษาพันถิ่นไทยนิรักสงบแต่ถึงรบไม่กล้าเอกราชจะไม่ให้ใครคุมขีสละเลือดทุกอย่างเป็นชาติทะเลทะลวงประเทศชาติไทยทวีพิชัยชโย
Dear honorable ministers from India and Thailand, distinguished guests, please let me welcome everyone again to this very important panel discussion. I am Nattha Komolvadhin from Thai PBS, and I'm very honored to be moderator of this very important session, especially how we can learn from each other in order to manage COVID-19 crisis. Especially right now, we see how the second wave pandemic has been hitting India quite crucially, but India has managed to cope with the situation in terms of trying to lessening the number of infection and the death. And Thailand is also being in very difficult phase of coping with COVID-19. And there are so many elements that many stakeholders in the two countries can learn from each other. And I'd like now to firstly introduce and invite Dr. Suwit Kunkitti, former Deputy Prime Minister of Thailand, to give introductory address. Please, Dr. Suwit.
Thank you. Thank you, Nattha, Dr. Nattha, for your introduction. Good afternoon, everyone, both in Thailand and India. Honorable Shri Wich, the Minister of Health and Home, the government of Haryana, and the Honorable Dr. Sathit, Deputy Minister of Public Health, Royal Thai Government. It is my privilege and honor to welcome you both and so many other dignitaries from medical and health professionals from India and Thailand. the other attendees to this webinar. I understand we have over 200 registration for the webinar. It is clearly a sign of importance of this topic, not just for the medical professionals, but for the community at large. The idea of this webinar arose when during my phone conversation with Dr. Komolvadhin, whom I had privilege to meeting a couple of years ago during my visit to India. I asked, the reason I called him because I want to know, that I asked him that what were main reason for such a sharp and speedy decline in COVID cases in your state and many other states in India after a devastating spell of Delta variant. And I was indeed impressed by what Dr. Komolvadhin explained it to me about how the crisis was managed by his states of Haryana and some other parts of his country. When I shared this with my medical colleagues and health officials here in Thailand, they also expressed a keen interest in learning about Haryana's experience to see if there is any lesson in it for Thailand. Also, I believe, given how damaging this pandemic continues to be, it will be worth a while to share as much information as we possibly can, so that our collective capacity to deal with the challenges is enhanced. Hence this webinar. Thank you, Dr. Komolvadhin and Professor Dr. Chanchai, President of Konkan University, and Professor Deepak Sharma, Director of Center for Global Challenges of AIT, for being the catalyst as well, the coordinator of this webinar. Thanks are also due to Ministry of Public Health of Haryana and the Royal Thai Government, Konkan University, a newly established Center for Global Challenges at AIT, Asian Institute of Technology, and the Thai Public Broadcasting System, which Dr. Nattha is our moderator today and help us broadcast to the public to be able to learn the Indian experience as well. So for joining hands to co-host this event, I would also sincerely hope that today's webinar will be the first in a series of mutual dialogues we will have on these and related topics in the time to come. With these words, I thank you all once again, and I look forward to stimulating discussion on the topic. Thank you.
Thank you very much, Dr. Suwit Kunkitti, the real man behind the scene of this very important session of panel discussion. Thank you again, Dr. Suwit. And right now, let me introduce Dr. Sathit Pitutacha, our Honorable Dr. Sathit Pitutacha, Deputy Minister of Public Health, Royal Thai Government, to give opening remarks for this session. Please.
สวัสดีครับ Honorable Anil, Minister of Health and Home, Government of the Haryana, Honorable Dr. Suwit Kunkitti, former Deputy Prime Minister of Thailand, health dignitary and all other joining this seminar. Please accept our greeting from Thailand. A few days ago, when Honorable Dr. Suwit Kunkitti mentioned to me about the impressive manner in which the Indian state of Haryana had dealt with the Delta variant crisis, and when he raised the idea of the organizing and information exchange session, I immediately jumped at the opportunity. I am so pleased that the discussion has resulted in the hosting of today's webinar. As we all know, the COVID crisis have hit the world hard and has caused enormous human suffering and economic loss. And the crisis continues, showing no sign for immediate relief clearly. We need to be fully prepared. The rapidly evolving and unpredictable nature of the crisis had made it very difficult to be fully prepared. However, in such situation, experience of the other, especially of those like your state of Haryana, which has very successfully contained the crisis, can be very valuable. I therefore believe that today webinar is an excellent opportunity for our health medical expert and health administrator to learn from their counterparts in Haryana, and for experts from Haryana to appraise themselves of how Thailand is dealing with the crisis. Such exchange of ideas can be beneficial for all. I very much look forward to the deliberation at the webinar. I would also hope that today's webinar will not be an off event. I would very much wish that we should use this webinar and exchange of idea and platform for building longer and lasting relationship between the medical expert of two countries, so that we can jointly improve our preparedness for dealing with such crisis in the future. In this seminar, I have Deputy Director General of the Department of Medical Service and Deputy Director General of the Department of Disease Control in this seminar. I wish you success. Thank you.
ขอบคุณค่ะ Thank you very much, our Deputy Minister Dr. Sathit Pitutacha, for giving us opening remarks. And of course, this is very excellent opportunity for Thailand and India to learn from each other. Now let me proceed to India's side, and please let me invite Honorable Shri Anil, Health and Home Minister from Government of Haryana. Please.
Namaskar. Honorable Dr. Sathit, former Deputy Prime Minister, Thailand. Honorable Dr. Sathit Pitutacha, Deputy Minister of Public Health, Thailand. Dr. Chanchai, President Khon Khin University, Thailand. Shri Alok Nigam, Additional Chief Secretary, Medical Health Education. Dr. Rajiv Arora, Additional Chief Secretary, Health. Shri Prabjot Singh, MD, NHM. Dr. Shaleen, Director, Medical Education. Dr. Veena Singh, DGH, Haryana. Dr. Dhruv Chaudhary from PGI Rohtak, and Dr. Sushila Kataria from our prominent hospital in Haryana, Medanta. Other participants from Thailand and India. It is a unique opportunity today to share Haryana experience with the authorities of Thailand. I am confident that your team will gain a lot from best in the state who have been tirelessly working day and night to save precious human life during the pandemic. The vaccination drive has been very successfully implemented, and I hope and I believe that the session today will enlighten you and your team to serve learning experiences and prepare for any disaster in future. State government notified the Haryana government epidemic disease COVID-19 regulation 2020 under Epidemic Disease Act 1897. On the same day, WHO declared COVID-19 as pandemic. Since then, rapid response preparedness for disaster management was activated. Health and allied departments have been driven into prompt action. Haryana is the first state in the country to issue daily bulletin on COVID-19 statistics since 3rd February 2020 to decrease the panic amongst general public. Government of India implemented complete lockdown in the country in April 2020 for more than 40 days to break the chain of infection. The same was strictly followed in the state of Haryana. It was continued for months with the step-wise relaxation. Even during the second wave, state implemented partial lockdown to control the spread. The first case in the state was reported on 17th March 2020 at District Civil Hospital, Gurgaon, and immediately statewide protocols were put into action. 2 molecular labs were established by 31st March 2020 to meet the load of COVID testing. Till date, 18 new government labs and 21 private labs have been added for expanding the RT-PCR testing capacity to 1,30,000 daily. 1,30,000 daily. More than 11 million tests have been done till date in Haryana. To address the infrastructure gaps, dedicated COVID care centers for mild patients have been established with the bed strength of more than 40,000. In all the 22 districts hospitals, more than 24,000 dedicated COVID beds have been provided. ICU beds with ventilators and BiPAP services were set up in all government civil hospitals, and capacity was enhanced in medical colleges and private corporate hospitals. Mapping of all the district civil hospitals with all the government medical colleges for referral of sick patients requiring tertiary level care. At the same time, procurement wing of the Health Department of Haryana, IHMSCL, ensures the supply of equipment, drugs, and consumables required for treatment of the COVID patients. To bridge the gap in human resource, more than 1,000 medical and paramedical personnel were recruited. Online training and capacity building through webinars were organized by senior clinicians, improve the clinical outcome. 13 million people were screened in house-to-house survey. In rural, urban, and migratory slums households by ASHA workers. And around 30,000 patients of influenza-like illness were diagnosed. Approximately 450 mobile health teams provided basic medical services along with testing facilities in far-flung areas. E-Sanjeevani and teleconsultations services were set up to cater to the health needs of the patients during lockdown. With all these above efforts, the state of Haryana was able to control the first wave of COVID-19 effectively. However, the mainstay of the management during pandemic was home isolation. COVID patients with no or mild symptoms were home isolated, sparing hospitals beds for more sick patients. During second wave of COVID-19, state of Haryana experienced increase of more than 10,000 cases per day, and the number of patients under home isolation also increased, reached maximum up to 230,000 in the month of May 2021. State and district level monitoring committees were constituted. It was ensured that home isolation teams visit the patients regularly. The patients were also called on daily basis, and most importantly, a separate team ensured the feedback from patients. The patients were also provided with home isolation kits free of cost, which contained booklets for information, pulse oximeter, steamer, digital thermometer, medicines, and Ayush immunity boosters. The world's largest indigenous vaccination program was launched by Honorable Prime Minister of India on 60th January 2021, and vaccination of all the healthcare and frontline workers was done in the first phase. Till date, approximately 14 million doses have been given, provided at free of cost. With the starting of second wave in 2021, the number of active cases rose manifold, approximately 1.15 lakh as compared to 20,000 cases in the first wave, resulting in increased hospitalization. Accordingly, the challenge to meet the demand of oxygen, drugs, beds, consumables, etc., state level committee of various administrative secretaries was constituted to assess the oxygen demand of COVID hospitals. The oxygen audit for analyzing the district hospitals requirements and accordingly need-based allocation was done by the committee. 9 O2 generation plants to meet the rising demand of oxygen for COVID patients were established, and our plan is to set up 130 more oxygen generation plants for government health centers having bed capacity of 50 and above. Also, 700 ventilators, 650 BiPAP machines, and 5,000 oxygen concentrators have been made functional during this short span of time. Increased requirement of healthcare personnel has been met out by medical education department by posting interns and postgraduate medical students of medical colleges and pharmacy, LT nursing students in various districts hospitals for strengthening the health service. To prevent spread in rural areas, Haryana Village General Health Checkup Scheme was initiated from May 15, 2021, and villages with high COVID load were taken on priority. And rapid antigen testing was the mainstay of screening. Till date, total of 1,73,79,228 were screened, and 1,10,928 cases of ILI were detected, and 5,164 positive cases were diagnosed, isolated, and treated to prevent the spread of disease. In addition to free testing and treatment at all government hospitals, inclusive of ICU care and high-end medicines and experimental drugs such as remdesivir and tocilizumab, the treatment service were also free for patients referred to private hospitals. The health department fixed upper cap of charges for COVID testing and treatment in private hospitals. A grant of rupees 5,000 was given to below poverty line BPL COVID patients in hospitals isolation, and ex gratia of rupees 2 lakhs in case of death. Health personnel deployed for COVID duty were given life insurance of rupees 50 lakhs. Besides the COVID services, all essential services such as routine immunization, institutional deliveries, and sick newborn care 24/7 emergency services, including surgery, were operational all through the pandemic. Despite several challenges and constraints, the state health performed expeditionally well in collaboration with Home Department to not only contain the epidemic but also reduces morbidity and mortality due to COVID. My team of doctors, experts, officers is here connected with your system for further discussion on how to control the spread of pandemic COVID-19. We assure to provide any kind of help from Haryana government in future if needed. Thank you.
Thank you very much, Honorable Chief Anil Vet, for playing out how the Haryana state coping with COVID-19 from the first wave of the pandemic to the second round, and how you have been dealing with this crisis. Next, let me move on to worthy Chief Rajiv Arora, IAS Additional Chief Secretary to Government of Haryana Health Department, to tell us more about COVID in Haryana perspective and a journey so far. Please.
Honorable participants, both from Thailand and India, our Honorable Health Minister Shri Anil has already given a very detailed background of what all happened during the COVID in Haryana and what all steps were given. So I will make a small PowerPoint presentation in which I will apprise the participants about the same in a little more expanded manner. Yep, you can start the presentation. Yeah, the first slide for those who are from Thailand, Haryana is a place which is located right next to the national capital, Delhi. And we have given the key facts and figures of the government of Haryana. We will also share a copy of this presentation with the participants. So I'll take less time so that everybody gets time to kind of participate in the webinar. So I would like to say that as far as Haryana is concerned, our major things which have been noteworthy, they have been the recovery rate, which has been more than 98.6% now. The mortality rate is 1.25%. The total sampling, as was already mentioned, has been to the tune of 11 million in the state, state with a population of just about 30 million. So we have already done a sampling of about 11 million. And as far as the vaccination is concerned, we have already had a vaccination of 10 million of the first dose and 3 million in the second dose. Whereas all over the country, if you see, in India, we have already achieved a total vaccination of about 540 million. Next. So this is just the organizational structure of the health department in Haryana. From the government point of view, we have the Honorable Health Minister. Then there's a separate department of medical education and research headed by my colleague Shri Alok Nigam. Then we have the Additional Chief Secretary Health and Family Welfare, where I am working. And we have these directorates, Health Department, Commissioner of Food and Drug Administration. Ayush is basically the alternate systems of medicine, which are there in India, and we are kind of promoting them in a big way. Then we have the Mission Director, National Health Mission, and the Managing Director of the Haryana Medical Services Corporation, which is the procurement arm of the Health Department. Next. So then these are basically the structures. This is only the government structure which I am giving here, the district civil hospitals, sub-divisional level, community health centers, primary health centers, and the sub-centers. But I would like to mention here that as far as the COVID pandemic was concerned, as much the government health infrastructure, even the private health infrastructure was involved in a very, very big manner, because we had the tertiary care institutions of Haryana government, the tertiary care institution of in the private sector, the corporate hospitals, the private medical colleges, and then a very large number of network of the private hospitals which are there in the state. They all supplemented the efforts of the government health infrastructure, which has been shown here. Next. Now, if I come to the
excuse me, the slide is not moving. Sorry.
आपकी मूव नहीं कर रही भी स्लाइड वहां पे
नहीं कर रहे हैं, वो पिछली देखना चाहिए।
इस पे ले आओ, ले आओ। Yeah, can you see this slide now? This gives the graphical presentation.
No, sir.
Yes, but
just front page. There's a cover.
तो भाई वो हो नहीं रहा क्या आपका?
Yes, it's coming. Thank you. Thank you very
Yeah.
much.
Yeah. उस पे ले जाइए graph पे ले जाइए. Yeah, I just want to give here the graphical representation of the first and second wave of COVID in Haryana. If you see on the left side, the first wave we count from the first case which came in Haryana on the 17th of March up to about February end, we call it the first wave. And if you see, it took almost 249 days to reach the peak in the first wave. And the highest positivity which was raised in the first wave was 19.01% on 16th of November 2020. But when it came to the second wave, we can see that because of the Delta variants and other factors, the steep rise in the second wave, it just took 93 days to reach the peak in second wave. The highest positivity rate entered 30.51% on 5th of May. And the highest positive cases in one day in the second wave was 15,786 as against just 3,104 cases in the first wave, the highest number of cases. So you can see that there was a tremendous amount of difference between the first and the second wave. And the second wave was something which put a tremendous amount of strain on the manpower, on the infrastructure, on the health infrastructure, on everything what one can think of. Next. Now this again is the same presentation. You see that what happened in about 7-8 months in the first wave, that happened just in 2 major months, April and May in the second wave. But we are very happy to say that now in the month of August, our positivity rate is just 0.05%, and we have less than 40 cases coming for the last about 1.5 months in the state of Haryana, which has already touched a total of 770,000 cases overall. But in the last 1.5 months time, we have had just about 3,000 cases in 1.5 months time. Next. So these are some of the advanced preparation of the first wave. Honorable Minister has spoken many things about it, so I will not take much time on that. Next. Next. Yeah, this is a very, I would say that this is the crux of our presentation, because what we did was that we had to meet the main challenges which were identified. The first and foremost was to at least establish the COVID testing labs immediately. Then the challenge to train and strengthen the existing manpower. Then the challenge to strengthen the existing infrastructure. Then the challenge to ensure availability of logistics, medicines, and medical consumables. The challenge to monitor the treatment of patients and control the spread of infection. At the same time, all the through a long pandemic, motivating the exhausting and demoralized healthcare workers and frontline workers. Honorable Minister has already said that we started just with the 2 labs, and today we have a capacity of almost 125,000 testing, RT-PCR testing per day. In addition to, we can do as many the rapid antigen tests as we want. And similarly, there are a large number of laboratories and other infrastructure which has been created in the private sector. We have the dedicated COVID care center for the mild cases. This is the distinction which we made as per the Government of India norms. Then the dedicated COVID health center for mild to moderate cases, and then the dedicated COVID hospital for the moderate to the severe cases. Next. So this has again been touched by the Honorable Minister, so I'll not take much time on this. Suffice it to say that this is what we got by way of a lot of government supplies. This, in addition to this, a large infrastructure also exists in the private sector in Haryana, which is supplementing the total availability of ventilators, concentrators, BiPAP, HFNC, and all the other things which are there. So this is the kind of preparation which is still an ongoing, it's a kind of work in progress, because we are, as the last slide would show, that we are still anticipating a third wave. We are not taking any chances, and we are now fully prepared and fully geared to take care of the third wave also. Next. So if I say, this again has been talked about, that there was a tremendous regulatory effort which was done, because normally the crisis times are the one where people also try to make a fast buck and they try to fleece the patients also. So there are 2 things which we did. One is that people who were below a particular level, they were provided total treatment free of cost by the government of Haryana. They were treated not only in the government facilities, in the government medical colleges, but also some of the hospitals which have been designated COVID hospitals by the Haryana government. There also the private treatment was also given free of cost. And in addition to that, those who could afford going to the private hospitals or had insurance on their own, they were going to the private hospitals, but we regulated and we put a ceiling on that what would be the rates they would be able to charge from the patients, what are the testing rates, what are the rates for the different kinds of testing. So all those regulatory decisions were taken. Next. Now, as far as the challenges of the second wave were concerned, so we had to ensure the medical and medicinal equipment available to all. As you saw earlier, we just got about 90 days time. Next year, please. We just got about 90 days time for the second wave in which the numbers went very, very high. And the one major area which demanded tremendous amount of upscaling, that was the availability of the oxygen beds and everything. Although we in Haryana are unfortunately sufficient in the production of oxygen, but because of the requirement of oxygen in the neighborhood of Haryana, in the state of Delhi, in other places, we had to share many of our available oxygen with the other states, and that created tremendous amount of strain on our facilities. So these were the kind of challenges which were there in the second wave. I have talked about the oxygen. Ministers have already talked about the special screening plan, which we started to stop the spread of the COVID to villages and rural areas. Because till date, in the first wave as well as in the second wave, the major areas which had been affected, they were the urban areas and not the rural areas. But there was a very great danger that once the COVID spreads to the rural areas, then it will become extremely difficult to control. And not only that, because of comparative lack of the infrastructure in the rural areas, then the stress on the medical infrastructure will be very, very high. And that is why we took a lot of steps to see that the entire rural hinterland is properly kind of checked and screened on a regular basis. And the people who are having those symptoms, they are brought to immediately the medical facilities right in the initial stages, so that they don't go to a level where they have to be put on the ventilators or the condition deteriorates. Next. So next is again, it has been talked that we tried to make available the medicines and other equipment. Next. We'll share this presentation, so I don't want to spend too much time on this. This is the entire system of the management of the oxygen which was provided to the COVID hospitals, and oxygen helplines were separately created, oxygen control rooms were separately created. Each and every truck which was carrying the oxygen, that was kind of tracked on a real-time basis, and it was seen that we are able to achieve a just-in-time inventory for all the hospitals which are there. Next. So these are basically the facilities which are there. We have given, we have compared on the blue side is the first wave, and on the yellow side is the one which is during the second wave. These facilities we have strengthened to a great extent during the two waves, and if I add the third wave, we have strengthened it to a further level in the third wave also. But that's an anticipated third wave. There's no third wave as of today. Next. So these again were the things which were taken up: the home isolation, timely referral of patients, monitoring the treatment of patients, helpline numbers strengthened, telemedicine, all those things. And then a very important part was added: the post-COVID care and death audits to assess the gaps, and also to see that what is the behavior of people post-COVID. So how they have to be kind of treated in post-COVID. There were a lot of complications, physical, mental, all kinds of complications. And so special Umang clinics were created for treating the patients who were suffering from mental ailments post-COVID. Next. So I'll now hand over Mr. Prabjot to speak on a few slides. Yeah.
Thank you, sir. Namaskar to all the participants. I would like to continue with the slide presentation. I would like to state that the helpline numbers, next please, the helpline numbers 1075 and one mobile number, they were operational since the beginning of the first wave. And we added many other teleconsultations also, like Ayush teleconsultation was added on the direction of Honorable Health Minister. Then we added mental health also, psychologists were added, and we have handled around 17 lakh calls and 1000 calls for mental health. Ayush calls were handled, teleconsultation was given for corona and non-corona things also. Next please. With respect to referral transport, Haryana is having 439 ambulances of different types, including advanced life support and BLS and patient transport ambulances. During the peak of the corona, when people were apprehensive regarding dead bodies, we have transported around 6,000 dead bodies of corona positive patients and 1,300 corona suspected patients. And we have also provided the real-time assessment of all the beds availability to the people also and to the government also. The apps were developed on which we can see whether the hospital is having beds or not, what kind of bed is available, whether it is oxygen supported, whether it is ICU bed, whether it is ventilator. Real-time assessment was done. Next please. We have used eSanjeevani OPD of Government of India. Honorable Health Minister has now directed to use it 24/7 and round the clock. Even at night times now our doctors are available round the clock. We are using it. Then we have developed home isolation kits, and specifically we have provided them with the mask, hand sanitizer, and digital thermometers were given. We have provided them with the steamers, and they were provided free of cost to their homes. Next please.
Excuse me. Slide is not moving again, please. And then could you hit the slideshow so we can see the whole frame?
Can you see the slide now? Are you moving?
प्रभजोत जी, इसको आप एक बारी पावर पॉइंट पे ले, उस पे स्क्रीन मोड पे ले लीजिए, ये स्लाइड मोड उस पे. हाँ, no, that's fine. Right.
Can you see them now?
Yes. Could you hit the slideshow button so we can see them? Yes.
स्लाइड शो बटन कर देंगे तो पूरा आ जाएगा.
We can see the full screen, please. Thank you.
Yes. Next, please. So regarding Asha survey, regarding vaccination, as you can see on the slide that on 16th
Sir, it is
of January.
not moving, sir. Slides are not moving.
ठीक है, यही रहने दीजिए. Can you see the slide right now regarding vaccination? Can you see it? This is the last slide. This is the last slide that we are having. Regarding vaccination, I would like to say that it was started by Honorable Prime Minister on 16th of January, and initially healthcare workers and healthcare workers and the workers of private health sector and government health sector were taken. Later on, frontline workers were added on 4th of February, and thereafter in different phases, the vaccination was open for general public, like for 60 year plus, and then thereafter for 45 to 60 year with comorbidities, then for 18 to 44. Right now, we have vaccinated around 14 million people, that is 1.4 CR, and second dose has been given to 3.3 million people. I would like to add that in the vaccination drive, we have seen that the enthusiasm of the general public as the vaccination was opened, enthusiasm was to be seen, and all the people, whether they are healthcare worker, whether they are frontline worker, whether they are people from the general public, they are coming forward. Initially, there was some kind of hesitation, but now they are coming in good numbers, and we are vaccinating it, and our second dose is also picking up very fastly. Next, please. Next is these are some of the pictures for vaccination, and next we have presented what is our preparation for the anticipated third wave. We are preparing for the anticipated third wave. It is predicted to be a pediatric wave, so we are preparing on all the fronts. We have trained our pediatricians. We are increasing our PSA plants. We are monitoring them on daily basis so that the oxygen shortage that has happened in the second wave, that should not be a problem. We are procuring the medicines like remdesivir and tocilizumab at a much faster pace now, and we are increasing the manpower also, whether it is medical colleges, whether it is our hospitals. We are providing them from NHM side also, and also the regular recruitment is also being done. So we are taking care that the anticipated third wave is taken care of properly.
So now I'll just request Mr. Nigam to talk about the tertiary care part of the COVID preparation.
फोटो कर दो, ये हटा दीजिए,
फोटो कर
स्लाइड हटा दो, फोटो। Namaskar. Greetings to all the honorable dignitaries and participants of this conference. As our honorable Health and Home Minister and my colleague Mr. Rajiv Arora has apprised you, we started from building up of labs, strengthening them with manpower and equipment, strengthening our ICUs, then creation of ICUs, and then establishing of critical care centers in our medical colleges, the tertiary care units of the state of Haryana. I'm really grateful and happy to inform that right from the Vice Chancellor of our University of Health Sciences to our nodal Dr. Dhruv Chaudhary, who is online, Dr. Sushila Kataria, doctor from Medanta, and all our directors have worked 24/7 during the COVID wave 1 and wave 2. There has been perfect coordination with the Department of Health and Family Welfare. So as soon as a person became critical, he was referred to our medical colleges. I'm also grateful to our private medical colleges who have cooperated with us. And we are preparing for a third wave. Hope it does not take place. And once again, I'm very grateful to all my team in tackling COVID wave 1 and wave 2. Jai Hind.
It's over to our moderator from Thailand for further proceedings.
Thank you very much. Thank you for the whole team from Haryana government in showing us in detail how you deal with first wave and second wave of the pandemic of COVID-19 in the state and how many stakeholders are trying to solve the problem together. So let's now move on to Dr. Veena Singh, Director General Health and Services, Government of Haryana, to tell us about HR, ICU services and post-COVID centers. Please.
On behalf of Health Department Haryana, I welcome the distinguished dignitaries, eminent panelists, and gracious participants of India and Thailand. Namaste, Swadika. Haryana, the home of gods. First slide. Haryana, the home of gods. Har means God and Yana is abode of God. Has its ethnic origin from Aryan dynasty. With rough and sturdy physique, Haryanvis are essentially a warrior race. Their main occupation is farming and serving the Indian army. History of Haryana has witnessed several invasions and has emerged victorious through ravages of time. Since the COVID pandemic hit the country and Haryana, Unanimous team effort by each and every Haryanvi is commendable. Despite heavy toll of second COVID wave, with average of more than 15,000 cases per day during the peak, today we stand tall and strong with just 22 cases per day. Haryana's fight against COVID is a unique example of hands-on dynamic leadership, both at political and administrative level. Honorable Chief Minister Haryana, Shri Manohar Lal Ji, has shown strong political will, administrative grit, and robust economy. Honorable Health Minister Shri Anil Ji, who is so rooted to the grassroots level, his constant monitoring, supportive supervision, and empathy towards mankind egged us on in this very difficult time. Worthy additional Chief Secretary to Government of India, Shri Rajiv Arora IAS, was due to his constant liaison with Government of India, mobilization of resources, information, and protocols, ensuring unending logistic support, and above all, was available round the clock for guidance at any hour of the day. Honorable Supreme Court of India ensured and monitored availability of standard treatment protocols to every citizen, irrespective of caste, creed, or socio-economic status. We had a unique strategy and there was a tactical planning. Two experts from Haryana were part of the National COVID Core team, Dr. Dhruv Chaudhary and Dr. Sushila Kataria, and we were constantly updated with the unending changes of WHO which took place because they too were learning. But they would share the latest way of approach towards the problem that we were facing and implementing. And since they were from Haryana and a part of the core team, so immediate implementation came into force. Rapid dissemination of information was done to the field staff by telecommunications. Being the DGHS of Haryana, my main responsibility was ensuring compliance at the grassroots level, as far as planning, strategies, and updating and availability of resources due to the great administrative skill was never a handicap. It was the implementation which was a huge challenge. We upgraded the secondary health facilities to tertiary level in the government sectors. Essentially, the district level hospitals are secondary level of healthcare. But the clamor of oxygen all over the place turned overnight our secondary level of treatment to tertiary levels where ICUs, ventilators, BiPAPs, everything was made available in a short time, and what used to be secondary care level overnight turned into tertiary care. Procurement of drugs and equipment was a challenge due to ever-changing prices. However, the team of HMSCL ensured uninterrupted supply. Simultaneous, and what was very unique about the second wave in Haryana was, even at the heat, when our cases were at the level of 15,000 per day, we were simultaneously planning for the third wave. Our vaccination did not stop. Procurement for oxygen and setting up a permanent solution, which was to continue for a long time, was immediately planned and executed. there was an acute shortage of staff, and you cannot create specialists overnight. So the only option left to us was, number one was getting the students from the medical schools, the final year students, the interns. They were simultaneously during this period, we had started online training for them. Students from the nursing colleges, the final year students, they were deputed to the tertiary care institutions and the civil hospitals. And the paramedical students also were sent to the various places. Arrangements, logistics, stay, food was planned overnight. There was reappropriation and rationalization of the allied health staff. We had districts which were closer to the capitals, and the better sought districts had more number of specialists, especially the anesthetists and pediatricians. They were re-recruited, sent on deputation to the various other places where there was a shortage. There was round-the-clock online training. Training of the unexperienced staff was the only way for us to move forward, and also was a preparation for the third wave. Since it was only the 10% of patients who required the tertiary care, our essential management was the home isolation and home quarantine, which accounted for 90% of the patient. What we ensured was the healthcare kit, which composed of, there was a mask, sanitizer, there was a pulse oximeter, steamer was made available. Telecommunication, as mentioned by worthy ACS and Honorable Minister, was on all the time. And we also managed home care visits by the health staff. We created micro containment zones, that is in the houses, and macro containment zones, or the hotspots, where a large number of cases were reported. We were in touch with the authorities so that enforcement of the macro containment zone was followed. Strict enforcement of COVID appropriate behavior, that is wearing of the masks, social distancing, hand hygiene, and prohibition of social gathering. In cooperation with the district administration, our civil surgeons were in contact with the deputy commissioners and the SPs of the areas for enforcement, because besides treating, it was also very important to contain the spread. Massive vaccination drives were on to build the herd immunity. Despite having it was a very fragile healthcare system, and the demand was high on every front, whether it was management in the hospitals, OPDs, but we did not give up vaccination, because what was going to stand us in good stead and which was going to last long was vaccination. And since our worthy ACS Shri Rajiv Arora ji, despite there were periods where there was a shortage of vaccine, but sir ensured a constant supply of vaccine to the state. And our instructions to our civil surgeon was stock out every day. Haryana and India is a country where the religious bodies and NGOs come together. Irrespective of our caste, creed, or racial discrimination, everybody got together, the society came forward, and there was a mass mobilization for testing and holding of vaccination camps. A large number of religious outfits not only ensured the gathering of their followers, but also provided food and lodging to our patients who were in home isolation, and also to the relatives when their near and close ones were inside the hospital. they were unable to meet them. Waiting outside was a huge number of attendants, and it were these religious bodies and NGOs who came forward and provided food and shelter to one and all. And there was another concept called oxygen langar. Since there was a clamor of oxygen all over the place, and making available tertiary care immediately was not so easy. They had ports where they had organized sessions where oxygen could be given to the patient on priority basis. A large number of donations started pouring in of consumables and equipment. We have a large number of people who were born in the soil of Haryana and were in fortunate positions, contributed immensely. We have an example of Deloitte company with one of our person who was in US. He made sure he took over the home isolation, adopted district of Karnal, and ensured home kits available. So we had the sons and from the soil of Haryana in the various parts of the world who came forward and made in their contribution. We made makeshift hospitals were made immediately overnight. We had a large number of corporate houses who came forward and made hospitals in Gurugram, Panipat, and Hisar. There was a provision, and I told you, despite the heat of the cases that was on, the preparation for the third wave was there. There was installation of PSA plants, concentrators were distributed all over the PHCs. They are the centers which are located in the villages and semi-urban areas, and ventilators were pouring in. And what I would attribute hugely why we have reached from single day maximum cases of about 16,000 to 22 was, number one, strict enforcement with collaboration of the district administration of COVID appropriate behavior, that was wearing of mask, social distancing, hand hygiene, and prohibition of social gathering, which was strictly followed. Mass vaccination, robust testing. Even today, even when the cases are as low as 22 per day, our testing figures have not gone down below 30,000. Continuous training. What is going to help us in the long time is training that we provide to the health personnel, to the paramedical staff, which is going to help us in coming time. Everything has a complication. The unkind COVID virus not only eats up the lung, it destroys the entire collagen fabric of the body. And we had a lot of patients coming up with post-COVID syndrome. And it was from breathlessness, body ache, weakness, and a lot of mental stress and anxiety that went with it, that the virus and the fear of the unknown was very high on the minds of the post-COVID patients. So for that, we have opened Umang. Umang means happiness in Hindi, that there is life even after COVID. Our centers have been open at all the district level hospitals, wherein we are providing mental health solutions, physiotherapy, treatment of the joints and the other comorbidities that have come in with the COVID. So a clinical, which is our key pillar is the clinical assessment, psychological intervention, rehabilitation in form of physiotherapy. I told you, it was a state which the entire state got together to fight the element called COVID-19. it was very difficult to pick up and find out that who contributed the most. But yes, everything has a fallback, and we pay tribute to the COVID martyrs. We lost our health workers from the Health Department, Haryana, 27 of them, and we pay tribute to them. We also do not forget the afterarm of the COVID-19. We have 1.2 lakh widows in India, and we have an equal number of orphans, something that we are going to take forward. Today's interaction, it is the end of my interaction with you, but the beginning of new horizons for future exchanges for healthcare and research. Thank you.
Thank you very much. Thank you, Dr. Veena Singh, for giving us so much in details how Haryana, especially post-COVID center, have dealt in improving life of people after facing COVID-19. And I would like to thank you again for all opening remarks by different sectors from Haryana government. Now let me move on to COVID in Haryana and what can we learn from current clinical management and post-COVID strategies. So I now like to invite Dr. Dhruva Chaudhary, Senior Professor and Head of the Department of Pulmonary and Critical Care Medicine and State Nodal Officer for COVID-19 Management in Haryana State, to tell us more about organizational aspects of COVID clinical services. Please.
Thank you, Nattha, and good evening to all my friends in Bangkok and Thailand. We are having a good afternoon here. So I think next 10 minutes, I shall be talking about the organizational aspect of COVID clinical services, which we established in our institution from where I am speaking, and also help the government as a technical advisor in establishing in the state. Already our Honorable Minister, Honorable Administrative Secretaries, and the DG Health has given a very detailed overview of that. Now, what was very important to realize is that COVID is different from other infections. We never knew about it. It spread rapidly. Situation was changing rapidly and dynamic. It was dynamic. So pathophysiology about the disease was evolving. Patients had no clue and they had an evolving symptoms. At the same time, to deal with it, we had to expansion the diagnostics. We have to see at the look at what is going to be the best treatment. So the treatments were evolving, and so was the virus. So it started from the Wuhan original strain, and today we are talking about Delta, Delta Plus, and Lambda strains. In between, we had Alpha and Beta also. Then the vaccinology came up, and that has been one of the biggest triumphs of the modern science. And then we have already started seeing the post-COVID effects of it, and the numbers have been there. As a critical care person, we have been seeing this post-sepsis, but now this has been utilized, and people will remember the history of the post-COVID effects. And what is very important is this: we have to do it with the disruptive social media, and we have to treat patients. We have to deal with these things in the glare of public and also the myths which were circulated. Therefore, what we realized is there were a heterogeneous group of patients, and there was a significant threat to life. And I will here like to quote Alex Haley: either you deal with what is the reality, or you can be sure that the reality is going to deal with you. And this prophecy has actually come out to be pretty true as far as the COVID is concerned. And what was required to build a vibrant clinical services like anything was the leadership. You needed governance, you needed preparedness, you also needed evidence-based practices so that we keep our things ready in terms of ethics that don't cause any harm to the patients. We also required collaboration within institutions, inter-institutions, with other institutions, and national and international level. We had multiple webinars with our colleagues from China, from Italy, from Europe, from US, and also at that point of time, I was the president of Indian Society of Critical Care Medicine. So we had multiple other associations. We joined together our hands with Indian Medical Association and Association of Physicians of India to train people. What was very important is as the virus was evolving, we needed to have an adaptability, and a lot of innovations who came up into picture. But what is very important was that we needed to take care of fulfillment of human needs when we started to going up. The hospital sector is a combination of hospitality, and sometimes we look at the prison wards. We are not too much aware about the hospitality which we learned during this epidemic. Also, we learned that we need to take care of men and women in the field if we want to have optimum results. So what was very important was, as you have said, what we are talking today as a one team from Haryana is because of the centralized command structure which was created, and at each institution we created it, and it had become the nerve center of activity for providing clinical services, for logistics, coordination, and human resource management. That was very important. And in this case, we used simply the computer line work which was available with an IT network, and we were getting dated, updated, and every single aspect of COVID was managed through this COVID center, which again, our DGH has talked about the project which we are doing it with Deloitte in Karnal, which our Honorable Health Minister and Honorable ACS Health has played a very significant role. So first thing, anywhere you do, you need space, you need infrastructure. Therefore, it was extremely important for us to identify the spaces, buildings, which should be isolated, which should have a separate entry exit. The zones have to be there, because there was nobody, people are talking about droplet infection, and nobody was talking about aerosolized, but the common sense says from where the droplet comes. Droplet comes from your airways. Therefore, it was presumed, we presumed from the day zero that this is an air spread. Therefore, that is why we were keeping entry and exit, and that's how the pneumonia was taking place. So air conditioning under those hot, humid conditions had to be stopped, and we had to innovate. It is easy to talk about negative pressure right now. At that time, we had no beds available except few beds in the private sector. And if you look at the people who are the high income countries, even they could not provide the negative pressure beds. So it is important is that when we are moving ahead with it, though we talk in terms of theoretically, but practically we had to deal with at the time of such what we are having it. So we had to create structures for triaging for the non-COVID services, because they have to continue, though they suffered a lot. In my institution, we had both COVID and non-COVID. And at the same time, there was an in-between transition of suspect, where you have to keep and you have to create separate pools. And we were fortunate enough to have more than 1,000 oxygen beds in our institution, because we are 2,000 bedded hospitals. But nevertheless, this was important for us to know. This was the place we ultimately, which was a little isolated trauma center, which we ultimately chose to be as part of our COVID care hospital. Again, we had to set up the ICU. They followed the 4 principles again. You needed to have a space, you needed to have a staff, you need to have a supply chain maintenance, and standard of care and also protocols have to be in place. Again, the most important besides space and equipment was the human resource. So we had to look at our institutional capacity. We followed the position of the Statement of Indian Society of Critical Care Medicine, which I am one of the writers of it. We looked at the workforce alignment, staff illnesses, and quarantine has to be taken in account, and so were the alternate strategies. So what did we do? We had a staff team we created from the doctors, nurses, and paramedic staffs, Group D staff also, support staff. What was very important, challenging was the initial inertia in the staff, the fear which was there, and who is going to take the ownership. So it demanded leadership. So therefore, we have to lead from the front, and we made a core group of a team, of which I have a privilege with to introducing all of you, and which will be participating today and will be sharing their views. So alternate strategy is what we look as our Honorable ACS Medical Education, Alok Nigamji has talked about. EICU was established in all the medical colleges, and that was a savior of us. Extra personnel, we got it from the Department of Dentistry. We also, the people who had recovered from the COVID, we tried to take their help, whether they were convalescent, healthcare workers, or the family members who provided the care to these patients. This is the EICU concept which we had done with the public-private partnership, and it has shown the advantages, how it amplified the care. This is the two-way communication in the ICU, and here I am giving as an expert opinion which was coming up looking at these cases. And trust me, the mortality reduced by 40% once we started putting the implementation of EICU. Each ICU bed, we provided ventilators with NIV HFOT. In my institution, we had all fully loaded things. Similarly, equipment and consumables were provided so that each bed, even in the high dependency unit, worked like an intensive care unit. We started with 10 beds and we scaled it up to 380 beds of intensive care in our institution in the second wave. PPEs was when we started up were not available, we were not aware, and obviously there was an extreme shortage. But I can say with a sense of pride at the end of the first wave, with the guidance and the enforcement of Mr. Alok Nigam, we were able to do so well in PP. The standards which we set in Haryana were followed now throughout the country, which we had also passed into the Indian Society of Critical Care Medicine. And we had an abundance of it when the second wave came, and we never had any shortage. Oxygen supply demand already has been talked about, but I think what is very important is more than ventilators. If you need anything, it is oxygen, oxygen, and oxygen. And we had various ways we have done it. At my place, we have 30 KL capacities. Now we have increased up, supplemented by additional 30 KL, and we are again supplementing with another 10 KL. So I hope not only that you have a supply, but ensure supply chain maintenance, and the pipes which are supplying, they should have the capacity to hold that load. Otherwise, it is of no good use. Transportation is an important, both intra and inter hospitals. And we realized because of the dead body protocols which were there, we required hush vans for either burial or for the crematoriums. Intra-hospital transfer was important to create negative wards or negative paths, which we did it. Infection prevention was the key. We created a young team of doctors and the nurses, and they really did it well. And we in-house, if you see it, we created and made UV chambers through which Dr. Prashant played a key role. Now it is in a public domain, which we have published now. Diagnostic services, already my colleagues have talked about. And this is the team which has done more than 710,000 RT-PCR, led by Dr. Paramjit Singh Gill. This is his whole staff. They have sent me photographs today itself, and we have 44,000 positive testing has been done. This was the first center in the state to start it, and we have upscaled it up. Then we also started centralized sampling so that people can, we have been doing at the peak up to 1,000 to 1,500 samplings. Similarly, mother and child services were ensured. This is our neonatology ICU, which has been there. We strengthened it. We made SOPs for the labor room, not only the institution of the whole state, and similarly for the neonatal management. I can say with a sense of pride that both my head of the Department of Pediatrics and Neonatology are part of the National Task Force in leading it from the front as far as the management of COVID in children and neonatal. Surgical services are also important, and we had made the protocols for surgical services for the whole country because the Secretary of the Indian Society of Anesthesia is our professor of anesthesia, and which is being followed, and this was followed in letter and spirit, and we never ever for a day stopped emergency surgeries and labor rooms. Yes, routine surgeries were cancelled, but later on cancer surgeries were added up, and they did it. As far as the best practices were concerned, we followed, and this is the protocol version 4, which is we are following it up, and it was based on acute disease severity and appropriate level of care. And triaging was the important thing, and that's what the Christina said. Triage pandemic is even thornier than you might have think, because it becomes a warlike situation as you are seeing in our neighborhood nowadays. We wanted to do a triage because demands are outstripping the supply. We created a very strict triage protocol, which was a rule-based system so that the persons who need to get into the ICUs or high dependency units. We wanted to do a public good of maximizing population survival. Public good means does not mean maximizing survival among those granted ICU, but it was among those, it is a philosophy among those who needed oxygenation and care and who were sick and who had the chance of retrievable. So the aim was the best enhanced population service, scarce resource. Government went into bed days so that more beds are available. From ventilator to the ventilator time, that we can plan accordingly. Medicines, again, we had to plan, so store. This was one of those protocols of tocilizumab, one of the toughest tasks in my whole life done. And thank you, our ACS and HM sir, for giving me that chance. And you will be surprised that we put a glutathione also here at certain places beyond a certain age group, because we had a very scarce supply. But I am happy we helped every single physician who asked where we did not care, and that has made a huge difference. And this is a nice protocol which we were following from NHS. That is that. If you ask me one simple challenge, that was the providing the care. Nurses dispense comfort, compassion, and caring without even a prescription. And what well said was told. It was the care which is why they're breathless. They cannot go their ambulations. They cannot eat it. They become breathless significantly. And probably that is the one which we required. And we innovated in our institution by taking the help of the people or the families were recovered or were volunteered and went our data, there was no in the attendance, and that improved the level of satisfaction. Emotional staff for the staff was as important for us because they were the backbones on the basis of which we were working. And what is important to remember, my dear friends, is most of the important things the world have been accomplished by people who have kept on trying when there seemed to be no hope at all. We started with it. Today we are at the end of the tunnel. We are seeing and hope, and vaccination is there. And that's what takes me to Srimad Bhagavad Gita, the scripture to which we all look up to, which says karma dhyanikare vastu ma phaleshu kadachana. That means only dharma is to fight and not worry who he was fighting or the outcome of the war. To be able to do what is needed without becoming attached to the result is the way of living a skillful life. What Krishna said in Mahabharata and the Gita holds true, and much more today in our COVID epidemic. And lastly, the best is the enemy of the God. So keep on trying. Thank you very much.
Sorry. Okay. Thank you very much, Dr. Chowdhury. It's very detailed and very comprehensive how you deal and quite creative way of working with different partners or different stakeholders in order to cope with COVID-19, especially from medical doctor perspective. Thank you very much. Now let me move on to Dr. B.G. Manjunath, Associate Professor, Department of Pulmonary and Critical Care Medicine, PGIMS Rohtak.
Hello, good afternoon, everyone.
Yes.
Dr. Manjunath is participant group and he's not able to share his screen. It would be very kind of you if you can sharing screen for Dr. Manjunath.
Dr. Pavan, can we do it with your system for Manjunath, please?
Sure, sir, we are doing that. Okay.
Please start, Dr. Manjunath.
Good noon, everyone. In the next few minutes, we will discuss how the state of Haryana managed its mild COVID-19 patients and what were the home isolation protocols. A mild COVID-19 case was defined as any individual who tested positive for SARS-CoV-2 using a virological test and who was either asymptomatic or had mild symptoms in the form of fever, cough, sore throat, malaise, headache, muscle pain, nausea, vomiting, diarrhea, or loss of taste or smell. At the same time, he should not have had shortness of breath or tachypnea of more than 24 per minute or hypoxia of less than 94% of SpO2 and didn't have abnormal chest imaging. And most of these patients were managed at their home. The data says that 92% of the patients of COVID-19 in second wave in Haryana were managed at home. And if that was not feasible, then they were managed at community-based centers which were dedicated to manage these patients, which had facilities for their stay, daily needs and monitoring, like public schools or hotels, which were named as COVID care centers. And the patient eligibility for home isolation was any patient who was clinically assigned as mild or asymptomatic case by a treating medical officer and who had requisite facility at his residence or self-isolation and for quarantine of the family contact, or else he was shifted to the COVID care center. A communication link between the patient or the caregiver and the healthcare system was always maintained during the entire duration of home isolation. And these patients were recommended to be kept in a well-ventilated room with cross ventilation and windows kept open to allow fresh air to come in. And the patients were advised to use a triple layer mask all the time, or even N95 when anyone else was entering this room. And they were advised to follow respiratory etiquettes, frequent to wash their hands or sanitize with alcohols, or not to share personal rooms with others, and ensure cleaning surfaces in the room that are touched often, like tabletops, doorknobs, handles, etc., with 1% hypochlorite solution. And they were advised to take adequate rest and drink a lot of fluids to maintain adequate hydration. And the critical components of home care isolation, home isolation care, were the equipments, teleconsultation, and the medical care, which was kept in the loop. The equipments mainly included the oximeters and the thermometers, which were either procured by the patients themselves and in most of the cases supplied by the government to their doorsteps. And the teleconsultation was primarily run by the medical students and the interns and the Ayush professionals. And when the need arose, clinical specialists were also included. And the dedicated COVID hospitals, home care support centers, and medical teams for home visits were always kept in the loop during home isolation. And any consultation at any point of the time of a mild case always included risk factor assessment for progressing into severe disease, like the age, the comorbidities, the family history of severe COVID, medications leading to immunosuppression or alcohol or drug abuse. And they were also utilized to form strategy and train the patients for monitoring. And the strategy was to divide them into either passive monitoring, which was done by the patient himself or herself and reporting SOS, or active monitoring, which was done by healthcare personnel through either teleconsultation or, if requirement be, even physically by home visits. And the parameters which were always included to monitor were the temperature and the respiratory rate, and SpO2 and 6-minute walk test in case of persisting or worsening symptoms or any dyspnea. We all know that 6-minute walk test is used to unmask the hypoxia in COVID-19 patients, and the patient was with a pulse oximeter attached to his or her finger was asked to walk in the confines of the room for 6 minutes, and any drop in saturation below 93% or an absolute drop of more than 3% or any feeling of unwellness like lightheadedness, shortness of breath while performing the test was considered to be significant, and early intervention in the form of specialist consultation or admission to hospital or shifting to ICU or additional treatment in the form of oxygen or in even steroids was recommended. And this test was modified to 3 minutes in patients with the age of over 60 years. And this protocol was approved by the Haryana government for management of mild patients. Those without risk factors were either isolated at home or COVID care centers and were asked to monitor themselves passively and twice daily and report SOS. And the treatment was mainly symptomatic, which included treatment for fever, pain, diarrhea, nasal symptoms, etc. And those with risk factors were asked to monitor themselves thrice daily, and even active monitoring was done at least once daily, either through teleconsultation, by call, or video conferencing. And even the cocktail of monoclonal antibodies, that is casirivimab and imdevimab, were used in selected subgroups. And most of the patients were prescribed budesonide 800 microgram twice daily or any equivalent inhaled corticosteroid from 3 to 5 days of symptom onset. And the clinical monitoring was further continued. And the drugs were not routinely used were ivermectin, HCQ, favipiravir, doxycycline, azithromycin, except in trial settings. And systemic steroids in the first 7 days of mild case were a strict no. And these were the indications for casirivimab, imdevimab cocktail, wherein if the patient was more than 65 years of age or had BMI of more than 34 or CKD, diabetes or immunosuppressive diseases or currently receiving immunosuppressive treatment was considered for this cocktail treatment. And there were other indications as shown in the slides. And a central committee under the chairmanship of state nodal officer, including multidisciplinary team, was formed to identify and justifiably use these limited resources to deserving patients, wherein this pro forma was set in, which was to be prescribed by the clinician who intended to use these, and the government itself supplied these drugs to the patients to the hospitals, and they were administered in daycare settings. And clear instructions were given to the hospitals how to store them, use them, and monitor the patients, etc. And for a patient under home isolation, indication to seek medical attention were difficulty in breathing, dip in oxygen saturation, persisting or worsening symptoms, chest pain or mental confusion, decreased urine output, poor oral intake, or any other symptom or sign of concern. And these patients were under home isolation, were discharged and isolation relaxed after at least 10 days from the onset of symptoms or from the date of sampling for asymptomatic cases, and no fever for 3 days. No repeat testing was done routinely. This was the flow chart followed. If the patient was identified as COVID positive by either by RT-PCR or RAT, he was contacted telephonically to the number which had been given during the testing, and they were divided into either fit for home isolation or institutional care. And those patients in home isolation, after 5 days, they were advised lab investigations in the form of inflammatory markers, or if requirement be, even radiological investigations were advised. And if they were normal, they were discharged after 10 days of symptoms. And if they were in the borderline category, then they were reassessed after 2 days. And if the inflammatory markers were grossly deranged, then they were asked to shift to isolation or take a specialist consultation. Thank you. Thank you very much.
Thank you very much. Now let me move on to Dr. Suchila Kataria, MD, Director and Senior Consultant, Department of Medicine and Infectious Disease, Medanta Medicity, Gurugram. Dr. Suchila Kataria, please.
Thank you very much. Thank you for giving me this opportunity. Am I audible?
Yes. Please go
Okay.
ahead.
So in the scarcity of time, I'll move fast. So I am here to discuss the management of more severe cases. What I'll take it from Dr. Manjunath. We'll be going through a case, and I will be underlining the salient features of management through the case itself. We know that COVID-19 disease severity has either asymptomatic, symptomatic cases, which is majority, but some are unfortunate to go on to moderate, severe, and critical stage. So one such patient is Mr. A.S., who was a 70-year-old male. He had all the features of high-risk chances of going to a severe disease. He was a long-standing diabetic, hypertensive, dyslipidemia, and he was on rosuvastatin. He had hypothyroid, and his BMI 33. So he presented on day 5 of illness. He was having low-grade fever, body ache, nose block, sore throat. Nothing alarming there. No breathlessness. Oxygen saturation was 97, respiratory rate 17. Blood pressure was okay. A few crackles on the left side, but you would by symptoms say that yes, he has symptoms of upper respiratory tract symptoms and does not have any respiratory distress. So he underwent all these tests, which shows that he had a COVID RT-PCR positive, and there was nothing alarming in all the reports. Just to see how things can change few days, this is the CT scan on day 5. We do not suggest everybody to have a CT scan, but he came with a CT scan, so we saw it, and you have it, there's not much. He has few shadows here and there on day 5. He's not desaturating, but he is a high-risk patient. If this patient comes, then you would think he had multiple comorbidities. Would you keep him in institution or in home? That depends on what infrastructure he has. So he had good infrastructure. We decided to keep him in the home care with symptomatic treatment. At that time, monoclonal antibodies were not available in India. If this patient comes to me today, I would definitely use monoclonal antibodies against spike 2 proteins, that is casirivimab and amdivimab. But at that time, we did not have that facility. So we gave him symptomatic treatment. We gave him inhaled corticosteroid, told him to monitor his parameters, advised him in detail about 6-minute walk test. And this is a perfect time to educate the patient on awake proning and breathing exercises. Even if they do not need it, they need time to practice it. So this same patient was in home care, and the consultant in home care found out that this patient needs hospitalization because he was still running fever on day 10. He was desaturating while using washroom. His inflammatory markers were increasing. And within 5 days, this is the CT scan, this patient, and you would appreciate the areas on both the sides of the lung, which were initially clear, had started showing these ground glass opacities, GGOs down. But at this stage also, in the resting condition, this patient did not have any desaturation. So sometimes it can be, a very much disguising thing. So this patient, because of the 6-minute walk test, was picked up, and because of the continued fever, he was picked up and was brought to the hospital. What did we do in the hospital? We started him on methylprednisolone. I use methylprednisolone. Both of my colleagues use dexamethasone also. So that you have to take your pick. But dexamethasone has been widely studied. Methylprednisolone is also equally good. Because he was in first 10 days of illness, we gave him an antiviral, remdesivir. There are reports of use and not to use remdesivir. We chose to use in this patient. We'll talk about this in little detail. Nebulization, all our hospitalized patients who are on oxygen needs anticoagulant, we gave that. But when you use steroids in a diabetic patient, you need a lot of help from your endocrinology friends, because titration in sugar is very, very important. Routinely, we do not use antibiotics in patients of viral pneumonia, so I didn't use in this. And we continued with the baseline care as well as antipyretics. Our care is not complete without a good nutrition, chest physiotherapy, and awake proning. This patient was made to put in awake proning. But in spite of this, he continued to run fever. The fever was so high and relentless that he would be given 3 to 4 grams of paracetamol in addition to steroids, but it would not break. The patient had excessive sweating, steroid dose was increased. So this patient was frankly going into a cytokine release syndrome. We had to go on to an insulin infusion to manage hyperglycemia. His oxygen requirement from 4 liter went to 14 liter, then went to 60 liters. CRP was continuously increasing. And because of extensive lung involvement, he developed SIADH, so he had hyponatremia. Overnight, the condition deteriorated. He had to be shifted to HFNC, and his CRP, IL-6, everything was increasing, but procalcitonin continued to be low. And I found that procalcitonin was a good indicator to rule out bacterial infection, which definitely you would like to use if you are using stronger immune suppression. So you will be aghast to see how bad the CT scan has gone within 24 hours. From 5 days back, which was normal, then it was slightly bad, and now this was the CT scan we were looking at it, and it was definitely a scary sight. We decided to use tocilizumab. Lot has been said about tocilizumab in literature. We started using tocilizumab probably as first in India to use tocilizumab in the whole country. But we, through our own experience, we devised a strategy. Initially, we were using 8 milligrams per kg body weight. But we found that lower doses is also equally benefit, and the risk of secondary infection was much lower. So as the protocol now, we use only 400 milligram as a single dose. We do not repeat. When we use tocilizumab, I started him on a beta-lactam inhibitor as antibiotic. Low molecular weight heparin was made twice. For SIADH, we were not able to maintain his sodium because of sodium restriction. So I gave tolvaptan, which was for few doses, and it helped. Supportive care was continued, and we continued with methylprednisolone also. The patient ultimately, after all this, was discharged in 36 days, but without requiring ventilation. He was managed on HFNC and with good supportive care. He further required 1 month of domiciliary oxygen therapy, and post-discharge 6 months now, he is up and about doing everything which he was doing before the illness. And this is his CT scan day 90 after he was discharged. So after 3 months of his illness, this is what he still had. Few shadows on the left side, but I mean, as compared to the last CT scan, you will all be happily surprised that it has resolved to this level. And we believe that the problem, if you continue to support the patient, the lungs improve and recovery is actually becomes easier. So now talking about why we use remdesivir. So mostly antivirals are repurposed, be it doxycycline, azithromycin, favipiravir, or even remdesivir. There is no mortality benefit approved in these antiviral drugs. So we used it, and then after our months of experience, we decided not to use any antiviral in milder cases. We use remdesivir only in the limited cases between up to day 10 of illness, in moderate to severe cases only. Steroids have been very, very instrumental in recovery from COVID-19, but we have to be very, very careful because it is a double-edged sword. If you're not taking care of other things like glucose, it can predispose to many secondary infections. Recovery trial established beyond doubt that steroids were helpful in reducing mortality. You could use conventional dexamethasone, which has a longer half-life, or a shorter half-life, methylprednisolone or hydrocortisone. The doses people have used from very low dose, 0.5 milligrams, to very mega dose, like 500 milligrams of methylprednisolone. We at our institute do not use pulse methylprednisolone, and we are always careful about tapering it and taking care of all the possible side effects, especially hyperglycemia and hypertension with this. Immune modulation is very, very important because the havoc is created by the cytokine storm. People do not die of viremia, they die of cytokine storm. So there comes the role of different immune modulators, the tocilizumab, baricitinib, and tofacitinib. Tocilizumab, we have maximum experience. We have used about in 1,500 of our patients. We have done a multicentric study which was published in Lancet and later became one of the cited articles by WHO when it gave guidelines on tocilizumab use. So in severe disease with rising CRP, in spite of steroids and increasing oxygen demand, we are very proactive in using tocilizumab. We use a single dose, we use low dose. We do not use IL-6 as an indicator for its use, and IL-6 levels minded will increase after using tocilizumab, so don't be horrified. Another modulator is baricitinib. It is a tablet form. It is used for 14 days and we give it along with remdesivir, have been found to be very helpful. Tofacitinib, we have limited use, but this is also one molecule. If you are facing the scarcity of tocilizumab, these are the alternatives which you can use. Always remember, the second week, starting from day 8 to 14 or sometimes 18 is the most crucial phase when your immune dysregulation happens. You should know the chronology is important. It is important to ask the patient which day of illness it is so that you can predict what you are going to use. So I will just conclude that be preemptive rather than reactive. Preemptive, that this is a patient of high risk, may have severe disease. So you are preemptive in, you are very quick in using monoclonal antibodies. And as soon as a patient of this type of thing deteriorates, you bring them to institutional care. Chronology of illness is important in predicting the outcome. CRP is an important and cost-effective tool. If you do not have IL-6 or other IL parameters, it does not matter. We always navigate and titrate our treatment according to the CRP. Do not rely on the symptom of breathlessness by the patients, because there will be patients you will see 70% oxygen saturation and not complaining of breathlessness, because happy hypoxia is very common. So always see oxygen saturation with your own eyes. Use immune modulators very timely. If you delay using the immune modulator for a long time, it is of no good. Care of nutrition, emotional support, physiotherapy is as important as other aspects of treatment. And the most important thing is to keep your team motivated. It makes a huge difference in the outcome. As everybody says, this too shall be over and we'll all be victorious. If I forget to say that, we are so thankful to be here and talking about this. And I am here in my personal capacity and from the government of Haryana. If I can be of any help to people of Thailand through telecommunication or any further communications like this, I'll be more than happy to participate. Thank you very much.
Thank you. Thank you very much, Dr. Sushila Khacharia, for sharing with us very encouraging presentation and how you deal with severe cases and how you have improved even though they are in severe symptom. Thank you. Now let me move on to Dr. Prashant Kumar, MD Professor, Department of Anesthesiology and Critical Care, PGIMS, Rohtak. Please.
Namaste, good afternoon, everyone, respected dignitaries and dear friends. So moving from the mild to moderate and now coming to intensive care management of COVID-19 and also regarding oxygen therapy, what we did in Haryana and how we managed it. We are still learning. That is my disclaimer for the day. So we have seen the infection leads to inflammation, and with antibody production, there might be recovery, but there would be people with severe disease where the lung infiltrates are there or oxygen saturation is dropping, or there would be critically ill patients who require multiple organ support because of the dysfunction. You'll end up in having severe disease in patients. So with the severe illness where there is a respiratory distress or respiratory rate is more than 30 breaths per minute, or SpO2 is falling less than 90, the mainstay of treatment remains steroid. Remdesivir was used as 200 milligram on day 1 and from day 2 to day 5 as 100 milligram once a day. But there was no evidence regarding effectiveness in treating COVID-19 patient was declared with WHO. But as Dr. Sushila has said, that for certain groups of patients coming with severe disease, it was used. The steroids in form of dexamethasone 0.2 to 0.4 milligram per kg daily, or methylprednisolone 1 to 2 milligram per kg or equivalent doses were used even within 7 days of symptoms onset if it was severe disease. The second line was injection enoxaparin or low molecular weight heparins plus tablet aspirin 75 milligram, and the oxygen support is definitely yes. If the patient improves, we continue the same treatment and taper the steroids gradually. But in cases there was no improvement, the steroid dose either was taken up or a pulse methylprednisolone with 250 milligram for 3 days was used. Also, there was use of evolving immunomodulators, and in cases of rapid deterioration, anti-IL-6 drugs like tocilizumab, Dr. Sushila has already talked about it, baricitinib and tofacitinib were also considered in combination with remdesivir and steroids. So baricitinib or tofacitinib, which are the JAK inhibitors, they had been used under the monitor of LFTs and RFTs. Tocilizumab, already talked about, and the government of Haryana has taken this very stringent form where these criteria were taken before getting any prescription for tocilizumab, and this had to be signed by at least 2 people, one from the intensivist or a physician or a respiratory physician. Then oxygen therapy used in all these severe patients started from nasal cannula, which we would have used from 2 to 4 liters and can give up to 44% of FiO2 with that, to coming to simple face mask, where it has a reservoir capacity of around 100 to 250 ml, which increases the oxygen reserve to the patient when the oxygen flows are used, and at around 4 liters per minute of oxygen, it delivers 35 to 40% of oxygen to the patient. Then we had used in higher concentration of oxygen by using partial rebreathing mask which has a reservoir of 1 liter capacity, and with this bag the oxygen concentration improves as the patient gets more oxygen. The last in these devices comes as the non-rebreathing mask, which has a unilateral valve sitting between the reservoir and the mask, and once the oxygen gets accumulated in the reserve bag, patient is able to inhale nearly around 95% of FiO2. Another devices which had been used are Venturi masks. So Venturis, they come in different colors, and with the different oxygen flows, you get different concentrations of oxygen. If the patients required more oxygen, then we had to jump to high flow nasal cannulation, or it warms the air, provides humidified oxygen, and it minimizes oxygen requirement and toxicity. So with the nasal prongs, we attach it to the inspiratory circuit, and the oxygen provided is heated and humidified. For non-invasive ventilation, either the full face mask or helmets were used. Helmets definitely had better patient compliance. So in terms of oxygen therapy, if oxygen SpO2 is on room air was falling less than 94, the patient started receiving oxygen from nasal cannula to face mask to Venturi or non-rebreathing mask. But if no improvement was found, patients were taken to high flow oxygenation or non-invasive ventilation. But even with these maneuvers, if the oxygenation was not improving, then we had to resort to invasive mechanical ventilation. Empirical antimicrobials were used till the diagnosis was confirmed, and local epidemiology of susceptibility was followed. Close monitoring, early detection of clinical deterioration is the key, and we need to have always an eye about the patient's comorbid conditions, because because of the comorbidities, we need to tailor the management of critical illness to all these patients. Requirements always remain dynamic, so a continuous monitoring of patient is very important for early recognition of worsening. In case we need to resort to invasive mechanical ventilation, airway was to be secured with all the precautions to reduce aerosol generation, and use of video laryngoscope was best for it. Strategies for invasive mechanical ventilations were low tidal volume, high frequency ventilation as in ARDS with optimization of PEEP, and avoid patient ventilator asynchrony. With the calculation of predicted body weight, volume assisted control remains the most favorite mode, and with the pH and plateau pressure remaining under the goals. The most important thing which we started doing and realized is helping people was the proning, and it was advised for all stages of hypoxia irrespective of severity or mode of therapy included, as Dr. Sushila already advised that the patient needs time to adjust to the proning and they can practice it. So prone ventilation improves oxygenations and decreases the mismatch. Patients were advised awake proning with the changing of posture after every few minutes, to proning even taken in severe ARDS with low tidal volume. Prone position had a maximum benefit in ARDS. Obviously, we had to avoid proning in patients who had increased intracranial pressures, pregnancy, obesity, or recent abdominal surgeries. So key points in management for severe patients remain intubation, mechanical ventilation, proning, and thromboprophylaxis. And this figure denotes the if the patient is deteriorating, we go from nasal cannula to high flow to invasive mechanical ventilation, proning, and ECMO. And as the patient improves, we come back to the same line in oxygen therapy. So there is a lot to be learned because virus is learning at much faster pace than us, and it is a totally unpredicted disease. Thank you very much. Namaste.
Thank you very much, Dr. Prashant Kumar, for sharing with us how to deal with intensive care management, especially on oxygen therapy and ventilation. Next, let's move on to Dr. Pawan Kumar Singh, Assistant Professor, Department of Pulmonary and Critical Care Medicine, PGIM's Rohtak, Assistant Nodal Officer, COVID-19, PGIMS, Rohtak, on case-based management of post-COVID-19 syndrome. Please, Doctor.
Thank you, Nattha. I will be sharing my screen. I hope my screen is visible to everyone and I am perfectly audible. A very good noon to everyone. So, given the paucity of time, I will go straight into my presentation. This is the place where I work. This is my complex of OPD. My presentation is based on a topic which is post-acute COVID. So like any person who is recovering from COVID, he suffers from a different kind of illness, and that is just like when the patient is out of the frying pan but into the fire. So beginning with the curious case of Mrs. M. She's a 45-year-old lady admitted in COVID-19 ICU with severe ARDS for over 3 weeks. She had been managed with remdesivir, methylprednisolone, tocilizumab, and many other drugs which are pertaining to ICU care. She stayed on HFNC. She had a complicated course due to her hypoxia. She was initially on HFNC, later requiring NIV. Then invasive mechanical ventilation. She was just salvaged from a requirement of ECMO because of the proning, later extubated, and was on Venturi mask at 40% FI2 after over 3 weeks of ICU stay. Repeat RT-PCR, which was done twice for SARS-CoV-2, was negative, and CRP had decreased from a high value of 110, which was her baseline, to a near normal value. Subsequently, she was shifted to a non-ICU area. And once she was out of ICU and life was looking all well, hoody-goody, then after day 5 of illness, she started day 5 of her shifting out from ICU, she started having increase in FI2 requirement. On the same day, she also developed fever and slightly worsening of her dry cough. We got a computed tomography of the thorax as a HRCT of thorax done to rule out any secondary hospital-acquired bacterial infection because she was iatrogenically immunocompromised. But CT scan was showing florid changes of ground glass opacity bilaterally with few patches of consolidations and few bronchoeclectic areas suggestive of fibrosis. But there was no evidence of any cavities or any secondary bacterial infection. Despite that, we got her blood investigations, which were procholesterol was largely normal. D-dimer and CRP were again suggestive of rising inflammation. So I would like to summarize at this point that she is a patient, middle age, over a month of oxygen requirement, persistent hypoxia. Despite initial improvement in her illness, there's no secondary bacterial infection right now. And still inflammation is ongoing. So what is this condition? What is happening to our Mrs. M? Is it post-acute COVID? Is it post-COVID? Is it long COVID? Or is it persistent COVID? How would I know? But thanks to the Englishmen, the NICE guidelines which were recently released, they explained this phenomena and labeled it as long COVID syndrome. The description is so beautiful that they have categorized into two different parts. One is ongoing symptomatic COVID and another part is post-COVID syndrome. The difference mainly between the two is due to the symptoms as well as because of the time and duration. The initial 3 months are labeled as ongoing symptomatic COVID, whereas symptoms beyond that are labeled as 12 weeks. This is a dynamic definition. I am pretty certain that after some time this will also change. So how do you differentiate between acute and ongoing symptomatic COVID? So ongoing symptomatic COVID is basically part and parcel of acute COVID only. The sign and symptoms that had initially begun as an acute COVID, the respiratory failure, the hypoxia that began as acute COVID, has persistent beyond the 4-week period. But the patient is right now negative for RT-PCR, that's all. And secondary bacterial infections have been ruled out. So this is ongoing symptomatic COVID-19, just like COVID-19, but RT-PCR is negative and there is no secondary infections. Whereas post-COVID syndrome is all different ball game. The symptoms are not fatal, but they are disabling. The signs and symptoms are largely because of the subclinical inflammation that is going on. Patients usually complain of fatigue, malaise, insomnia, memory loss, fall of hairs, but still there is no fever. So main differentiation between the two is lack of fever, and still the patient is having some kind of illness that is not explained by any other cause. So coming back to our case, we have labeled her as ongoing symptomatic COVID because she is beyond the first month of illness. Now, what does NICE guidelines say about management? The management mainly focuses on the symptomatic management as well as giving some medications like anti-inflammatory, coenzyme Q, NSAIDs, and antifibrotics. But giving the positive time, I am not going to go into any details of coenzyme Q or NSAIDs because they are largely harmless drugs used only for symptomatic management. But my main focus will be on anti-inflammatory, antifibrotic therapy relevant to our experiences in Haryana. So what anti-inflammatory drugs are available to us? Our loved ones, the most common, the corticosteroids. They are time tested, relatively cheap, easily available, and almost available in any kind of formulation that is available over the counter. But they are not associated with anything but few cons like hyperglycemia, neutrophil dysfunctions, and the possibility of secondary infections like mucor, which caused a havoc in our state of Haryana, the discussion on which will be taken by Dr. Aditya. So basically, this is one thing that is truly labeled as a double-edged sword. Other immunomodulators that are available but do not have any data supporting or against them are immunosuppressants and immunomodulators. So what are the alternatives? Sorry?
Please wind soon, sir. We are short of time.
Okay. Immunosuppressants, I'm not going to much detail about them because there's no evidence. Immunomodulators, two the most common are Baricitinib and Tofasitinib. They came into picture after the studies in NHM. This is our own experience from Haryana, in which we established that role of Tofasitinib is in improvement in WHO ordinal scale, and significant improvement was there in patients who were persistently having inflammation. But still, there is no data in late stages. Late stages for ongoing symptomatic COVID, we have used JAK2 inhibitors, that is Baricitinib and Tofasitinib, in almost 23 patients. The age has been around 46 years. Most of them patients have been beyond the second week of ICU stay. The oxygen requirement has been 40 to 60%. Most common complaints have been fever. In all those patients, we started with steroids, but only for 5 to 10 days. But we started using tofacitinib more than baricitinib because it was cheaper and easily available. The outcome, all of the patients were off oxygen by the end of 2 weeks. Duration of hospital stay was less than 2 weeks. Fever was first to resolve and there were no secondary side effects. Nintedanib and pirfenidone are commonly used in our country despite having no evidence, though there is a biological plausibility. So in PubMed right now, even after 2 years of evidence generation and crunching, there are only 17 results using Boolean operators for COVID-19 and nintedanib. Out of those 17, there's only one study and one case report. And even in that study, the use of nintedanib was only in acute phase and did not show any mortality benefit or any improvement in oxygenation. So back to our Mrs. M, we started on methylpred oral therapy tapered over 12 days in addition to tofacitinib. Oxygen requirement tapered over 2 weeks. She was discharged after 15 days and later after 5 days, tofacitinib was stopped. This is her follow-up imaging, which is showing a remarkable improvement after 1 month of discharge. I'm not saying this is all because of tofacitinib or methylprednisolone. A major chunk of contribution has been due to the time that she was provided of therapy after a month of her discharge. So that was period that played a critical role in resolution of symptoms in imaging. But summarizing, COVID-19 is not only an acute disease. Long COVID is a common disabling disease due to relentless inflammation. Evaluation of long COVID can be easy with basic investigation of CRP. Steroids is not the only answer. Support therapy is the pillar. Alternative immunosuppression will play a significant pivotal role in the coming days. Evidence generation about any disease, about any illness is a part and parcel of medicine, should not be ignored. I will conclude my talk by statement given by William Osler that making policies without research is like cooking without recipe, and research without practice is like cooking without ingredients. Thank you. I will conclude my talk on this note. Thank you.
Thank you very much, Dr. Pawan Kumar Singh, on sharing with us the case-based management of post-COVID-19 syndrome. Thank you. Next, let me proceed to Dr. Aditya Bhagrav, MD, Chairman, State Task Force on Mucormycosis, Senior Professor and Head Department of Otorhinolaryngology, PGIMS, Rohtak.
Sir,
Please.
I may request the subsequent speakers that they should be please brief and to conclude, so that we are already running ahead of time and we have to wind up soon also. Thank you very much, please.
Thank you, sir. We'll take care of that. Good afternoon, everybody, and Jai Hind. Mucormycosis, it was a COVID-associated epidemic. Sudden spurt in cases of mucormycosis in COVID-19 pandemic struck us like tsunami and created panic among the population and the medical fraternity both. Managing patients and educating people both became our challenge and responsibility. In initial phase, due to inadequacy and of the availability of resources, it became a little bit complicated. But with proper triage and prioritizing of patients for early surgical intervention helped us in preventing life-threatening complications. We made a mucor task force under the orders from Haryana government and our director and vice chancellors. It was led by the Department of Ear, Nose and Throat. It was a multidisciplinary approach, which was the key to success. Department of Ophthal, Department of Oromaxillofacial Surgery, Department of Neurosurgery, Internal Medicine, Anesthesia, and Microbiology were part of this task force. Initial glitch was fighting a war like without arms. With over 300 patients, till date 395. As on day, we chalked out our management protocols. Fighting a fungal infection without adequate supply of antifungals was the real challenge. Amphotericin B shortage led to the risk of reinfections and residual disease even after adequate surgical debridement. Patient and media outcry were to be dealt with on daily basis. It was like ammunition was falling short. Both man and machine relationship was getting distorted. As you say, man behind the machine is important, but machine and ammunition is also very, very important. It was a surgical marathon. Our strategy was our operation theaters were running full throttle. Here I must mention that our anesthesia colleagues, they shoulder to shoulder fight with us. They were not even bothered about PA checkup and all, whatever cases were being taken, and this was being operated. With the restriction in surgical operating instruments for mucor, we had to restrict only 2 operating tables, which worked almost 12 hours a day without any holiday. Follow-up endoscopies and residual surgical debridement was the strategy we stuck to so that recurrences can be dealt with timely. Surgery of 268 patients of mucormycosis was done in just over a period of 2 months. Almost all patients underwent check endoscopies and required revision serial debridements were taken up. Outcome. Mucor with COVID became an entity which behaved differently and had to be dealt with in somewhat different manner. There were a total of 69 deaths only, but 13 could be attributed directly to mucormycosis and rest were due to COVID-related complications. Pulmonary mucormycosis cases also cropped up, which had a higher fatality. Our experience total. Pre-COVID era mucormycosis patients were not rare, but they were uncommon. These were the patients who were immunocompromised, diabetics, and other immunocompromised status. The incidence at that time used to be around 2 to 4 patients maximum in a year. First wave of COVID, that is April 2020 till March 2021, we saw a spurt in mucormycosis during the first wave, in which we saw around 21 patients, which were treated at our hospital and were discharged after surgical and medical treatment. Second wave of COVID, April 2021 till now, with second wave, we have seen even a higher spurt in mucormycosis. Total 395 over a period of around 3 months. In a day, the record was about 65 patients in a day. After initial glitches, adequate amphotericin supply was restored. Present situation is under control. Areas to be explored. What lessons we have learned and what we are going to get out of it. What is the role of steroids in this part of mucor cases? What is the role of iron, zinc supplements, which are being blamed? What is the role of COVID-19 virus? Difference in mucormycosis cases pre and post-COVID. Thank you very much. And Jai Hind.
Thank you, Dr. Aditya Bhargav. Thank you for sharing with us your body of knowledge in dealing with the early cases of COVID-19. Next, Dr. Dhruva Chaudhary, Senior Professor and Head of the Department of Pulmonary and Critical Care Medicine and State Nodal Officer for COVID-19 Management in Haryana State, sharing with us lesson learned and the way forward. Please.
Thank you. We are already running short of time, so I will very quickly go over it. As shown earlier, there was an enormity of challenge which we had in Haryana in the second wave, which we saw up to 16,000 plus cases in a day. So what lessons have been there? I will quote Manisha Juthani, who is an ID specialist at jail. Humanity memory is short and what is not ever present fades quickly. I think this is the lesson we should learn first, because in the first wave, we became very overconfident that we will not be struck by the second wave. And you see what has happened in the second wave. So remember history, recognize history. That is the first lesson I will say we have learned, and which unfortunately in the South Asia, we are not very fond of, but history tells us how things will happen. What is important is that we need to be prepared for unexpected. We need to remember that masks are a useful tool, and if anything which is going to save you more than the distance is the mask. So please wear mask. That's an important lesson. We need to maintain line of sights of patients. That's what we realized, that we started seeing and treating patients from phones, etc. When we are not evaluating, it led to the increase in mortalities in the hospital. But it is important that the patient must always be kept in sight, including the care. It gives you an idea. Similarly, we need to mind the air quality, the transmission, especially in the hospitals and also in the public, because that is how the transmission is taking place. And if you want to decrease the transmission, this quality has to be there, and it is important from the public health perspective. We need to follow evidence-based protocol. Dr. Bhargava just shown you the right, left, center use of steroids, uncontrolled diabetes, not being taken control, led to an epidemic of mucormycosis. We need to maintain caches of supplies and diversify supply chain. Like war reserve, each country now, outages have been there in USA, in UK, also in Europe and other places. Therefore, we must maintain caches of supplies and diversify supply chain. The savior for us has been the technology, as I had shown you, EICU, and also our home care isolation protocols. Emotionally, we need to invest in healthcare workers. We need to train them. They are our forces. Man behind the machine is the key. And what is the important lesson we are learning is that vaccines must be done and are a powerful tool. Also, our leaders should realize it that health and economics are interrelated. Health is not only a science, but it is also related to a lot of social functions and without health, you cannot do any economic activity. Same way we have learned that because of COVID, education has also taken a backseat and learning deficits are coming up. Health inequality and diversity is widely prevalent, has been shown. People who had the money went to the private sector. People who didn't have anything came to the government sector. That's what we learned. But what was the key message was the communication. The messenger should be able to communicate properly with the team, within the team, with the patient, within the tenants, and within the care providers. But we also learned that we are having a marked resilience in the human race. It's something like we were ambushed, we kept our cool, we dealt with it. Those who dealt it with coolly, they survived and sailed through. And that also led to an important aspect of mental and social health. Now, way forward for us is healthcare infrastructure need to be upgraded across the board. And we need to put new in these cases, technology at the forefront. We need to start for preparing for the surge now, not when the surge is taking place. And we need to prepare physicians and nurses. And if you ask me, my money will always be on paramedics and nurses more than the physicians. We need to strengthen protocols, training, and technology. Home care based, you can see it in 94% when the peak was there, we managed people who are mild to moderate disease in the homes. Triage protocols have to be in place, ingrained, and people should just reflexively act on that. The protocols, but must be evidence-based. Telehealth and teleeducation is the way forward, and time is coming now for the molecular epidemiology and collaborations. Oxygen supply chain, by simply increasing the storage is not good enough. You need to maintain the turnover time in the supply chain. And here, all aspects will be there because the major thing starts from liquid medical oxygen. You need to have a PSA oxygen concentrators in the hospitals, but nevertheless, all aspects needs to be taken care. End-to-end supply chain should be maintained. Community participation is the key. Mask we must wear. We need to have a strong community and leadership support, which fortunately we have in our country. Our health minister has been one of the, who himself suffered from COVID, and he has been one of the pioneers and the Path Pradarshak, or the man who is showing us the path in our state. Vaccine is the savior, and we must go for the vaccination. And the myth which are there, they need to be removed. So it should be friendly, implantable, and ensure equity. That is there what we are seeing. The people who have the money, the nations who have the money, they're talking of boosters, whereas Africa and a large number of other countries we are seeing still not being done. These need to be cost-effective, accessible, and available. We are fortunate in India, though it took some time for things to streamline, but we have already vaccinated at least once 50 crore of the people. In my state, nearly 66% of the people have been vaccinated at least once. Remove myths which are there, need to circulate it. And finally, I will end with what Mahatma Gandhi said, and it was published not in by the Lancet, which said that faced with today's crisis, what will Gandhi do? I think it will begin with an action that initially are small. That means we start from the community. We will not simply preach and come and talk, but we will act and practice ourselves. We will act locally and not chase the word to change. So the change has to start from within. We need to have interfaith and social unity. We need to care for the sick. We must have a freedom from the fear and ready to accept and make prayers. I think that is the way forward. That's how I look at it at the philosophical note. Thank you very much.
Thank you, Dr. Dhruva Chaudhary, for sharing with us lesson learned and the way forward. Next, Dr. Ujjwala Gupta, Director, Integrated Disease Surveillance Program, Government of Haryana. to share with us extending COVID care to the villages, HVGHC scheme. Please.
Please start, Dr. Usha Gupta, please.
सभी को मेरा नमस्कार, स्वागतम. I am Dr. Usha Gupta, Director, State Institute of Health and Family Welfare. This institute is Apex Training Institute of Haryana. So my topic is Haryana Village General Health Checkup Scheme. So these are the few pictures of this scheme, what Haryana has implemented during the second wave of COVID-19. Objective of Haryana Village General Health Checkup Scheme are as under: to screen the rural population of Haryana for COVID-19 suspected cases in a campaign mode. Early detection of suspected cases and their rapid antigen test, RT-PCR testing. Early isolation of positive cases to break the chain of transmission. Treatment of positive cases near to their home so that villagers can stay and get the admission near to their home. Building a robust healthcare system at village level. These were the objectives for this scheme. Our Honorable Chief Minister, Shri Manohar Lal Khattar, has envisaged Haryana Villagers General Health Checkup Scheme for containment of COVID-19 and general health checkup of entire rural population of Haryana. It has covered almost all the villages of Haryana, that is approximately 6,700 villages were covered during this scheme. This is a huge number of villages to do the checkup of all villagers in a very short period, in a campaign mode. Teams were constituted, basically two types of teams were constituted to do this job: field team and village headquarter team. That strategy adopted was test, trace, track, and treat. That field team consisted 4 members, basically Asha, which is from the village itself, Anganwadi worker, that is also from the village itself, school teacher, and panchayati members. Basically, civil surgeon try to include lady panchayat member for this scheme. What was the role and responsibilities of field team? Basically, the main role and responsibility of field team was to screen the population for influenza-like illness, severe acute respiratory infection cases, general health checkup of the entire population, and referral of suspected patient to village isolation center. These village isolation centers were set up in the center of village itself. Village headquarter team members consist mainly health members, which can be multi-purpose health worker, that is also at the level of sub-center, whether it is male or female. Lady health visitors, pharmacist, LT. It was depends civil surgeon availability of manpower, whatever available at that time. Non-health members, basically from school, engineering department, education department. Data entry operator were also engaged for village itself. That role and responsibilities of village headquarter team was taking history, detailed history of villagers, conduct general checkup of villagers, selection of symptomatic suspected for rapid antigen by RAT team. Symptomatic RAT negative, which were negative in RAT test, but they were symptomatic. RT-PCR tests were performed as per Government of India protocol. These are the equipment which were provided to the village headquarter team. thermal scanner, pulse oximeter, medicine kit, oxygen concentrator. These were the equipment which were given to the team members. There was rapid antigen team also to conduct the rapid antigen test. More than 2,000 persons were trained for rapid antigen test, and it was ensured from the headquarters that at least one person should be trained from the each sub-center level. Massive trainings were conducted to before launching this program. More than 46,000 participants from the health department and non-health department were trained to create the awareness among the Panchayati Raj institutions. The trainings were also important through the EduSet channels to the teachers and students, because they were also involved for this screening, because health system was not having sufficient manpower. So education department, Panchayati Raj department were also included for this massive task. YouTube link were created to train the persons. Medical officers of PSC and CSC were also trained for this scheme. Videos were used to train that medics and paramedics so that they can easily understand how to take pulse oximeter, how to use pulse oximeter, how to take BP, etc. From the health system, each and every multi-purpose health worker, whether it is male or female, and sub-center in charge, ANMs, LT, pharmacists, etc. were trained for the COVID management. As I told earlier, more than 2,000 participants were trained to conduct the rapid antigen test before launching of this program. This is the statistics of Haryana Village General Health Checkup Scheme. This was launched on 15th May and will had continue for the 15 days. So you can see this statistics, more than 35 lakh household were covered during this scheme within 15 days period, and more than 1.73 CR persons were screened and general health checkup were done during these 15 days program. And persons who were suspected for ILI and SARI, that rapid antigen tests were conducted. That is again more than 1.3 lakh persons where rapid antigen tests were conducted. And test positivity rate during that campaign was 2.84% for rapid antigen test, and persons who were having symptoms but rapid antigen test was negative, that RT-PCR was done for those villagers. And more than 65,000 RT-PCR were performed during that campaign, and positivity rate was for RT-PCR was 2.15%. Planning for rescreening. When this scheme was launched, it was seen that there was many villages which have a high positivity rate. So to bring down that high positivity rate to lower, it was decided that where the villages which have the high positivity rate, we should done rescreening of population after 15 days to bring down the positivity rate and to cut the transmission chain. So re-screening round was decided for those villages. So re-screening was done from 1st June to 14th June. And this is the statistics of re-screening data. During the census of 2011, total population of Haryana was 2.54 crore. And rural population of Haryana is 68%. That comes to 1.64 crore. So entire population was screened during that campaign. During the re-screening, more than 13 lakh persons were screened, and more than approximately 20,000 RAT was done during that period. So you can see how positivity rate came down during that period. Earlier, the red positivity rate was 2.84%, and after the rescreening, it came down from 2.84 to 0.40%. And RT-PCR, approximately 15,000 RT-PCR were performed during the rescreening, and positivity rate came down from 2.10 to 2.08%. So this was the very successful, this was the scheme. What we gained during this scheme and screening, that spread of disease to rural area was rapidly curtailed by active screening of rural population, identification of vulnerable population with comorbidities, and the identified cases were treated near to their home in villages. What challenges Haryana faced during the first round of this scheme? All the work was performed manually, so there was no software that time. So difficulty was found in coordination among the team. So lesson learned. What was the lesson which learned by this round? To overcome these challenges, a digital platform was formed with the name of Gramin Swasthya Suraksha mobile app. What is the Gramin Swasthya Suraksha app? As part of preparedness for third wave, this app was developed by the IT department of Haryana. The master data from all the districts were already entered in this app, and the trial entries are being made as the part of preparedness by all the districts. All the necessary trainings have already conducted. So when in case third wave arrives, we can launch again the second round of Haryana Village General Health Checkup Scheme within 2 days. Now we have a robust IT system, robust app, which have already downloaded by our ASHA worker, multi-purpose health worker, our medical officers, and now we will be having all digitalized data. Our medical officer from the PSC, CSC can check from the dashboard.
Time.
So this is my
Please
presentation.
conclude, ma'am.
Thank you. Thank you so much. Namaste.
Thank you very much. Thank you, Dr. Usha Gupta, for sharing with us how do you extend COVID care to the villager, especially population in rural area. Thank you very much.
Thank you.
So now let's move to very important section for our discussion today. It's panel discussion. And please let me invite Dr. Gopal Bajwal to be moderator of this very session. And I'm so sorry that I need to leave the seminar discussion right now. And I have to ask Dr. Suwit Kunkiti, former Deputy Prime Minister, to be moderator in junction with Dr. Gopal for me, please. And I need to say goodbye for now. And I learned a lot from discussion today, and very sorry that I need to leave early. สวัสดีค่ะ Thank you very much.
สวัสดีครับ สวัสดีครับ Thank you ครับ It's my honor to take over from you. Thank you. Yes, may I invite Dr. Gopal Bajwal to continue and moderate the question and answer sessions, please. Dr. Gopal. I can hear you. You have to unmute. Thank you. Thank you.
It is unmuted. I think you can hear me.
Yes. Yes. Very good. Thank you.
So we will now have a panel discussion with question and answers. And to start our discussion, I would like to invite colleagues from Thailand to ask their questions. I will then call upon my own colleagues in India to share their answers. So first, I would request Dr. Peron, would you like to ask the first question, please?
Or make any presentation, please, Dr. Pirun.
Yes. Please unmute yourself.
I think because the limited time, so you still need the presentation or just the question?
I think if you have to present little bit, we will be welcoming that. There is no problem.
Yeah.
We can hear from you, no issues. We can have at least 5-10 minutes, at least a little extended session, little bit.
Yeah.
If you want to say something, we'll hear from you. No issues.
Yeah.
Thank you very
I would like to present some information from Thailand first.
Sure.
To let you know that what we have in Thailand right now. So.
I will request Dr. Dhruv, please be online so that.
I'm there.
Thank you so
Gopal,
much.
I'm there.
Thank you. So Dr. Pirun, please.
Okay. Okay. I just, good afternoon, all distinguished participants. I will give only short presentation of the COVID-19 situation in Thailand for a few minutes. In Thailand, we have around 70 million population people live in Thailand. 50% live in urban area, and I think we have the first COVID patient in January last year, in around 13 January last year, and the first epidemic in around March last year. And right now we have another epidemic wave in start at April this year, the 1st April. And you will see the steep rise of the total cases of COVID and death from the graph. And right now we have around 100,000 people confirmed case of the COVID. It's near million cases right now. And we have the mortality rate around 0.83%. It's less than 1% of the mortality rate, but it's still high in our sense. And around 20% of the cases is still have the ongoing medical care. 25% of them stay in the hospital, and we have around 1,000 people still on mechanical ventilation. And as you know, that's as in the other countries, that more than 80% of the COVID was the Delta variant. I think like in India, that just passed the epidemic already, but we still in Thailand, we're still in the epidemic. We have the COVID-19 care system in Thailand. I think it's quite the same as in India. The patient will stay in hospital or few hospital or in the hospital. We also have home isolation and community isolation. We have the guidelines of Thailand about management of COVID patient. We certify the patient due to their symptom according to WHO criteria to mild, moderate, severe, and critically ill patients. If the patient has no symptom, we will isolate them at home, or the government pays for 14 days, but no antiviral given. If the patient had mild symptom but no pneumonia or no risk of progression, we will give favipiravir for 5 days. With the patient may stay at home or in the government place such as hospital or hospital or few hospital. But if the patient have pneumonia with underlying disease, we will admit the patient in the hospital for at least 14 days with favipiravir for 5 days or more, and we will give the corticosteroid if they have pneumonia progression or hypoxemia. And if they have severe pneumonia, we will give extended course of favipiravir and corticosteroid, and maybe add on lopinavir and ritonavir for 5 or 10 days. We also have remdesivir for the severe pneumonia that we will give within 48 hours after admission, and the patient who need the high flow or the pregnant women who have pneumonia or the patient who cannot eat oral medication or have the problem with absorption. In Thailand, we also have herbal medicine called andrographic paniculata that give for the patient who have mild symptoms. The data from Thailand say that it can prevent progression to pneumonia. For vaccination in Thailand, I think currently we have 26% of the patients have the first dose of vaccination, and around 8% have the second dose of vaccination. And and the third dose is around 7. And the third dose around 1% had the third dose as booster dose of the vaccination. The Sinovac and AstraZeneca is the most frequently vaccine that we give to the people. And the other vaccine is Sinopharm and Pfizer. 54% of the vaccine give to medical personnel, and around 20% give to the elderly people, and 11% to general population. And this is the vaccination situation in Thailand. That I think is the same. It's quite progression of the vaccination in Thailand as in the other countries. I think this is all the data that I will show with the Haryana to give information for discussion. And the question that we want to ask to Haryana is what is the most important factor that's control the COVID-19 epidemic in India? Is lockdown or herd immunity or early treatment? And what is the treatment regimen of COVID-19 in India that is quite different from Thailand? And about the success of vaccination of scheme in India and how to manage the overwhelmed patient during the epidemic. Thank you. That is my presentation and question.
Thank you. I request Dr. Dhruv Chaudhary, please answer to the queries raised by Dr. Piran.
Thank you, Dr. Piran, for an overview of the problems in Thailand. Your first question, in terms of it, what led to obviously it came like a blizzard and stayed there for 6 weeks and then disappeared practically from the north. That's what we saw. I have been saying it, it was like a tsunami, and it created it. Now, probably one of the very big reasons we find out is the two reasons. First and foremost is once we started the lockdown, the transmission started going down. So lockdown definitely. So if we look at a COVID appropriate behavior, one part is vaccination and second part is the distance. And then the social behavior of the people. So the three things which were there, that was taken care of. Once it was there, so lockdown and the strictness on the part of the government to ensure that lockdown is there. And also people accepted it because of the severity, the way it was ravaging it helped us. That is one part. Second, also, there is a probability, because we are in the process of zero survey, how much our urban and the other populations had it. So probably there is also a possibility a large number of people, symptomatic, asymptomatic, got infected theoretically. That we will come to know through the zero survey. So these are the two things, combinations which probably helped us doing it, because in Delhi, we are finding now nearly 55 to 60% children getting infected. And in the certain areas and pockets of Delhi itself, which we surround on three sides, the national capital region, Haryana forms a large chunk. Practically, the numbers of positive people are 70% and above. That is first part. Second is that our place also, the vaccination maximum has taken place with Covishield, that is the AstraZeneca. And the second is the Covaxin, the inbuilt, where I have been participant as a co-investigator in it at our center where we started up. And 85% our vaccination primarily is with AstraZeneca. By and large, what we are seeing is breakthrough infections are there. And the data, when we look at it from CM Christian Medical College, Vellore, or from ICMR, practically we are seeing it that compared to Public Health England, whatever the data we have, nearly more than 80% efficacy, we are finding it up. And even with the Covaxin, the data which has come up, it has been showing AstraZeneca and Covaxin, which is a killed vaccine like your Sinovac and Sinopharma. But with the one major difference is that here we have addition of a compound which helps toll-like receptors. So we have a better cell-mediated immunity. So that's where again efficacy is nearly the same that of AstraZeneca and your Covaxin in our country. Third part is as far as the breakthrough infections are concerned. Like I have a data of my own state where we looked at of the physicians who were vaccinated. I have breakthrough infection data of 136 where we removed 10 because they gave it somewhere else. They're all physicians of the state of Haryana in practice and otherwise. There was 124 cases. In terms of percentage of severity of the disease, by and large, in percentage point, there is no difference. But significantly, looking at it, the number of people who fell sick this time was much lesser in the healthcare or the people who had vaccination. Fourth point I want to make here is that there was no difference in the second and the third week. As a member of a Lancet Commission, we collected the data in terms of age group at which people were infected in the second wave. It practically is the same. Mortality percentages are the same. The only thing is that everything got crowded and came within 6 weeks period. So what we saw over a period of what Mr. Arora showed us, that there was a very sharp hike, there was a spike which was there. Earlier we were blunting the curve, we couldn't do that. And that was the nemesis for us. And another thing with your question, which I will say is that when we looked at the epidemiology, we realized that large number of social events, large number of events of political and public and religious interests were taking place in the country. And the rural area and urban area, we are not finding any difference in all the sero surveys which have come up to us. As far as the treatment protocols are concerned, there has been a lot of criticism of it within our own country in terms of evidence-based, or people have gone to an extent that quackery was at its best because the fear and fear had taken over the people. And favipiravir, initially people had used, lopinavir, ritonavir was used last year, but once the recovery and the solidarity data came up, nobody using it. But I know, and that's what we see it, that earlier, whether it was MERS-CoV or whether it was your SARS-CoV-1, it was never used alone. The combination was used with ribavirin or interferon gamma, and the study which came from your Hong Kong showed an excellent results. So if you're combining two antivirals, what it comes up, I don't, as far as the SARS-CoV-2 is concerned. But yes, favipiravir, we are doing a in computer, in silo, computing of the various drugs for the repurposing. What we found was favipiravir, remdesivir was a shade better in silo trials than favipiravir. And what we found in those trials were hepatitis C drugs, like that you are looking at ledasotovir or your Decla. They were the drugs which were, and sofosbuvir. These are the three drugs, but out of them, Lido had the highest activity against this mRNA viruses. But we are doing a trial. Iran has done it, but still a lot of data needs to come up. But favipiravir, I know, and it's first pass metabolite, the drug which is there being used in Russia and Japan extensively, but still it has not been able to do it. Similarly, we had seen ivermectin also. I did speak to the gentleman who was from Bangladesh, Dr. Syed, who has been dealing with it. I again says, because 85% of our patients will not have any problem. Therefore, whatever you may, one can always claim that we are also saying so, people are saying so, we have found it to be effective. I think we need a robust data in coming times. Perceptions are there, one. As far as the national protocol is concerned, now from the ICMR has gone to the National Center for Disease Control, where a lot of criticism is there. Now in the mild disease, we are not choosing anything. So the data which Dr. Manjunath showed, that slide, that is being followed. Budesonide has been put as a part of, because Lancet showed some amount of evidence there in terms of people doing better. And we have now put in our state protocol. Center still has to put up because it's a lot of cost issues. But we could do it because we had got it as a part of, the government of India had given us the immunoglobulins, cocktail, that is going to play a lot of role now. But the cost is the issue. As far as the moderate to severe, there was a lot of criticism in terms of use of steroids, the way in India it has been used. But again, there has been advantages as for the evidence But we have done in the process of analyzing our data, where we try to use in severe patients, methylprednisolone pulse. Now, European Respiratory Journal, other journals have published it now, that in sick patients, probably a short course of high doses working, and then you're going back to that standard one. Because for 40 kg and 100 kg, same dose cannot be working when this is a lipophilic drug. So probably you need much more. So these are it only shows that, yes, this is what we need, this is useful. And in India, that's why you must have seen that one thing written, no steroids in for 7 days, because a lot of people were using early and it has been counterproductive. As far as the severe is concerned, no issues, tocilizumab. Sushila talked about that trial, we were all part of it, which has got published in Lancet Respiratory Medicine, where we used it. We did not find 25. So bottom line is give adequate steroid on the dose from 800 to 400.
Yes, may I ask that one question?
Thank you.
Was you was mentioned about lockdown completely. What do you mean lockdown completely? Because lockdowns is different in definitions. Like in Thailand, we call lockdown, but we have curfew in the evening. But during the day, we ask people to stay at home, but they still go around. So what do you mean the complete lockdown? How long have you locked down before you really, push the number down and come to the levels of today?
You see, the lockdown, Dr. Suvit, was announced on 4th of...
Paramveer will give his input, Dr. Dhruv, regarding the lockdown, because he was monitoring the lockdown in the state. Yes, Dr. Paramveer?
Yeah, hello, sir.
Sir is asked, what is lockdown? How do we enforce it? The micro and macro
containment zones and all.
Hello, sir. I'm Dr. Paramveer, and what we did, we divided.
Can you switch off one of the devices? Just mute rest of the devices.
Yes, sir. So we did. There is a lot of people.
There are multiple devices open there.
More than one device is open in your room.
I
mute all the devices.
Dr. Paramveer to share from my area, if you can come.
Yeah.
Please come to my room and you can share from my area.
He will share it. Dr. Veena, I will just share the clinical experience. The lockdown was declared on 4th of May, if I remember the date correctly. And we had the peak on 6th of May. As a clinician, we started seeing the decline after 15th of May. So once we started looking at it, and this time, initially it said the government has put certain restrictions, but once you started enforcing from 4th onwards, and the difference started coming up, and by early part of June, practically the tail had come of the epidemic. And that is what people have been seeing it in other states also, that the peak stays 6 to 8 weeks. That's what I said, the two reasons. One probably is a lockdown. And second is that at that point of time, maybe the people who are coming in contact with the virus, they probably all had become some amount of
community had developed by then.
That combination of these two things work. But still no definitive answer is there.
But lockdowns, you mean the whole day, the curfew, whole day, not allow people to go out from the house?
I'm
the whole day, or
Dr. Paramveer to speak on that. Yes, please.
So what we did, we allowed the people to go out of the house only for essential services. Like emergency services were allowed, only essential services were allowed during that time period. And the services which were not essential, only those were restricted. And the major part was that during that lockdown period, we focused on making the containment zone, both at micro level and macro level. even each and every house was treated as a containment zone. That way we were able to contain the spread of the disease. We went for rapid antigen testing, and our major focus was RT-PCR test. We didn't rely on antigen tested during that period. 75 to 80% of our testing was rapid RT-PCR testing. And through that, we were able to assure ourselves that this much population is being affected. And we were able to contain the disease to a specific location during this lockdown period. And as Dr. Dhruv also emphasized, that it was for a period of 6 to 8 weeks. And during that period only, there were restrictions, but we were able to cope up because of those restrictions only. Thank you, sir.
You see, Dr. Suvit, people became scared at that time. So what happened was that it was a part, a very large extent, a self-discipline which came into play. So I think that helped us a lot. So, but in the first phase, when it was last year, it was a very strict lockdown. This time, once the disease picked up, people really got worried and they started staying at home. I can tell you that the roads had become empty. So I think that helped us to a very large extent. Plus additional factors that when we looked at the reproductive numbers and all, this time whole families got infected. What we had seen last time, it was not that much there. So probably some amount of the virus also hit the dead wall somewhere. So, but these are all conjectures. We still need to do a more detailed analysis. It came, it conquered, and it went away.
Thank you, Dr. Dhruv.
Thank you. Thank you very much.
Now, can I request Dr. Precha? Would you like to come in now?
All right. Thank you very much, Excellency, and all the colleagues from India. So thank you very much for your informative information. I don't present anything because Dr. Pitutacha already present situation in Thailand and what the control measure in Thailand do it. So I just have a question that Dr. Suvit already mentioned. As the lockdown, we can say that in Thailand we also starting lockdown just on the beginning of August, and then now we think we try to be exit the lockdown. So what is your criteria of the exit of the lockdown for your country, for your province? That is the first question. The second question is about because you say that you do a lot of rapid antigen tests. So I would like to ask that you have the plan to have the self-test for the people. Is that you have the policy to do that or not? So because Thailand we plan to do that on the self-test, so people can do rapid test by themselves, and then they can go to outside. Or we plan to have that control measure because of in the maybe next 2 months. We plan to open the country, and then we can say that we have to let unlimited. I mean the people can traveling to the place, and they can test themselves before they go out to some place like that. Suppose you go to the supermarket, to go to the mall, department stores, so you test them yourself first, and then go to you can use that facility support like that. So you have that kind of thing or not. The third thing, you mentioned a lot of treatment, which is we thank you very much because of the Dr. Nattha Komolvadhin. He already left because he have another conference, so he asked me to give your information on this for the treatment, because Department of Medical Science, medical service, they developed the CPG, clinical practice guideline for the country. So we have a lot of things that you have a lot of things that we don't have it. Maybe because of our limitation on the monoclonal antibodies and other thing. It was IL-6, some anti-IL-6, something like that. So is this possible that we can get some information or get some to some kind of support on this thing, because of I think that this is very important for the severity case in Thailand. You know that right now we have around more than 1,000 cases in the ICU or respirator. So if we have the we can get some of the treatment for the new severe case, so we can use for that one. So I just have this thing of question, and I don't know. This is the other thing that we talk about your embassy. The embassy in Thailand talk with us about the Phuket sandbox, that we will can let Indian people go to Thailand on the Phuket sandbox in Thailand, or not. You can, I don't know, you heard about this or not, the Phuket sandbox. Okay. Okay, 3, 4 things. Thank you very much. This is really informative and very useful for the Thailand very much. So thank you.
Thank you, Dr. Picha. I just first request Dr. Veena Singh to speak on the lockdown part of a question, and then I'll request subsequently Dr. Dhruv to answer remaining questions of him, because there is a quite elaborative questions, and I think only Dhruv can take those all questions.
No.
I request.
I'm very
I'll
confident.
start with Dr. Veena,
Dr.
please.
Dhruv is our leader, and we have a very dedicated team, very updated, who have been hands-on handling the problem of COVID. Yes, lockdown is a very good idea. They should completely go ahead, and they should do it in phases. Instead of having a complete lockdown, which is a huge burden on economy, should not happen, but it should happen in phases for a certain period of time. You should start first with weekend lockdowns, then timing, the daytime lockdown, nights allowed. I think Sir Dr. Vadera can answer that better. Dr. Vadera.
I think with the judicious use of the lockdown and timely intervention in the form of monoclonal antibodies, we will be able to preempt the serious cases and contain them. Basically, it is the serious cases and the mortality which is the worst part about this disease. So in case we have judicious lockdowns, and in the people where monoclonal antibodies can be given in the early phases of the disease, if we use them, you will find that the patients with comorbidities do not get into a phase where the disease is so serious as to warrant an indoor admission in the intensive care unit, and that is where most of the mortalities happen. So we should be able to pick the cases very early. In first 10 days, monoclonal antibodies can be given when they are very effective in the first 5 days. So try to decrease the number of admissions in your intensive care unit. That is the best approach towards it. And to contain the disease, lockdowns wherever they are needed must be done. Thank you.
You see, Dr. Picha, I think lockdown is something which politicians are very scared of because of the fact that it has hit the economy very bad. And they're always very circumspect about it. And we also saw it in our country also, because at the second time, we did talk about the micro containment zones and other things. What we did find, what was useful was the tracing was that if you can do a digital tracking, we tried to do it with one of the apps, but people have learned how not to do it. But like what Taiwan did it, they did the tracking of the people with their mobile phones. But if we do it today in India, it will be a big ruckus in the democratic countries. So I think people don't like that. But somewhere we need to see the activities of the people with the high risk behaviors who are moving. It's not simply lockdown. What is very interesting is that what is the social behavior of the people at that particular point of time? Because when you are coming in touch with each other, the idea of lockdown is that you're trying to put rigidly you are trying to see that you don't come in contact with each other so that it doesn't take place. So I think social behavior is very important, which we need to hit at it. We look at that. That's what I'm saying. When lockdown happened, the number of cases are so high and the media help needs to be there. It was being shown on the screen that people got scared. Everybody got touched. So we suddenly saw that the roads which were full suddenly became empty. We couldn't see. So I think that is very important. So the social behavior contact is the key. But most important for me, what I have realized from the practical perspective, that is the policy perspective, is the mask. If we ensure double mask to everybody, even if they come in contact with each other, practically you can reduce the transmission rate by 80 to 85%, which is a huge number. And because end of the day, if I look at the classical epidemiology, you being yourself an ID people, we look at the susceptible population, we look at infected population, we look at it who have been exposed and who have recovered. So I think looking at it, the data which are there, probably what we have to see with the Delta variant also, we have seen it, that if you're vaccinated or you had in the past, again, the Public Health England is showing, our data is also showing not more than 10% people are getting reinfected. So some amount of crossing is there. But if lockdowns have to be effective, ideally they should come before the peak takes place. And I am certain with Mahidol University, with Comcare universities, you can do a mathematical modeling and see the areas which are coming up and going up. And what we have learned the hard way, Haryana, we started last year, and we are hopeful that this year we will be successful, is an epidemiological surveillance. That is how it will be picked up. Now, suddenly all the Government of India labs have gone up. That's why I put it up, the way forward is a molecular surveillance. It is not COVID. It will be like influenza. It is other diseases which are there. So probably that it is a beginning point for us to now invest in the basic scientists. It's not that you need a microbiologist. The people with the universities are great help. When we expanded our diagnostic labs, I remember the Chief Secretary calling me. He said, we need it and we are not getting anything because the whole world was locked. From where did we got the RT-PCR machines? We got it from our universities. Our university, within 1 week, we had 28 machines lying with us and the people who were using it. So I think what is very important is it has to be integrated and it cannot be different approaches. So
Dr. Dhruv, I really feel very proud sharing the plan that Haryana is going to do is a very robust sero survey. The sample size is going to be 36,000. The kits have been procured. The population has been identified, and that will truly reflect the state of sero levels of the population of Haryana. So the 36,000 sero survey will be submitted by the end of August, and that should help us to predict the further journey of COVID-19.
Dr. Veena, I will add to one thing. Dr. Usha is there. I think kudos to her the way she has worked. But most important, Dr. Suvit, what we found was the coordination, the leadership. I think whatever we do it, we had an excellent leadership. We had a technocracy, bureaucracy, and political leadership all working together with the name. I think that changed the things. So that is what is required. That is what we need to do. And rest we can do in isolation. But unless until these three things will not come together, that's what I said, even within the hospital itself.
But Dr. Dhruv, in Haryana, strong political will, administrative grit, implementation of what has been planned is what has been really helpful.
Absolutely. That's exactly I'm saying, Dr. Veena. And I want to share you with one experience which can help you in Bangkok actually, is that when we looked at our capital, financial capital, that is Gurugram, which is adjacent to Delhi, we realized that we had a very poor public health infrastructure. I remember that was 26th of May 2020. When we re-looked at it, in 2 weeks, we had 20 line channels opened up. On the WhatsApp groups, we use technology innovatively. All the hospitals, public and private, are on there. And we realized in the dashboards, real time, that how many number of beds are there, how many ambulances are moving. We created the plasma bank. We realized on the dashboard how many are available to us. I think that sort of a central control command is very important.
We leveraged we leveraged the facilities that we have. So, and that really helped us to implement better.
Same thing.
I request all the panelists that we are running short of time, and I would have liked to Dr. Nattha. I think he's not available right now. So if there is no any more questions, we should conclude the question answer session. If you permit, if you have any questions, we welcome it.
No, I think that Dr. Pichai, you have any more questions, sir?
Sure. So if there is no questions, then we thank you all.
Something, Gopal. Dr.
Sir,
Pichai,
you want to come in?
Dr. Pichai, sir.
Yeah, Dr. Gopal, I would just briefly want two of my young men, Dr. Amit Fogart, who got the ventilators working, and Dr. Paramveer, who has been a key force in installation of the PSA plants, the liquid tanks.
I think it will be 1 minute presentation from your side as intimated. Thank you.
Good afternoon, sir.
Please.
Myself, Dr. Amit Fogart. I was involved in basically deployment of manpower and regarding operationalization of the ventilators. So one of the issue was that ventilators could not be made functional at that time. So we provided training to the anesthetists and deployed the anesthetists wherever there was lack of manpower. So in short, we did this only.
Thank you. Thank you very much.
This exercise converted our secondary care district hospitals became ICUs overnight by this strong effort that was made by the team. Dr. Paramveer, the update on PSA plants and ensuring that every bed in Haryana is available on that.
Please.
Good evening, sir. Sir, I looked after the installation of PSA plants and availability of oxygen across all of Haryana. With the guidance and with the trust Honorable HM entrusted on me, we were able to create a portal. Through this portal, we were able to get the real-time monitoring of all the real-time monitoring of the all oxygen beds which were occupied, which were available. We got the whole real-time picture of that, and we were able to get 6 PSA plant installed under PM Care. Honorable Prime Minister of India donated 6 PSA plant. We were able to get them installed. At that point at the beginning of second wave, we had only 6 PSA plants. Now, today we have 33 PSA plant and another 139 are the procurement procedure is under process, and we'll get them installed too. And regarding supply of oxygen to each and every bed, with the help of Honorable Health Minister and Director General Health Services, we were able to give financial sanction. We were able to get the financial sanction, and now every hospital in our government health facility are supplied with a gas pipeline, and we will be able to supply oxygen to each and every bed in our government-run health facility. Thank you.
Thank you so much.
Thank you very much. Thank you.
I would request Dr. V.K. Bansal now.
Steroids, everything was available in the pharmacies of all our health centers. Dr. Jyoti.
Good evening, everyone. Myself, Dr. Jyoti, and I am looking after the availability of all the essential drugs required during the COVID pandemic. And we have ensured that all the drugs like remdesivir, tocilizumab, amphotericin, like the post-COVID complication, we have also provided the amphotericin B injections too. And we have already a procuring agency like Haryana Medical Service Corporation. We send all the demands, all the indents to the Haryana Medical Service Corporation for procuring the same and to manage the supply chain. There will be no interruption in the supply chain of managing all the cases of COVID-19. And we have also sent many drugs, and best part was that at the time we are not able to provide some equipments or medicines at that time. Then we have got many equipments and drugs and consumable items through CSR donation. The best part was that from other countries also we have receiving like that. And thank you very much.
Sir, The moment we received the concentrators, the oxygen cylinders, we distributed them immediately where they were required the most. So even distribution of the CSR made by the Sons of Soil of Haryana reached where they were meant for.
So
Thank
now
you.
I request Dr. V.K. Bansal, please have his talk and presentation. And we conclude the panel discussion. Thank you very much.
Good evening to everybody. Thanks to all the participants for their valuable contributions. Although today's webinar has come to the end, but this is the just beginning of the journey of the relationship between the health authorities of both the sides. We would like to share information, scientific knowledge and experience in the field of clinical research, operational and administrative developments, and not only with the regard to COVID-19, where we stand united, but in other areas as well. We are open to extend our help and support to Thailand health authorities in combating the diseases and saving the mankind. What I can foresee today is that we would be having more of such webinars, trainings, interactive sessions to support each other in developing our health services. Thank you all of you.
Thank you, everybody.
Hello. Now I request the Honorable President Konkan University, Thailand, for the concluding session. His remarks.
Good afternoon, Mr. Anil, Health and Home Minister, Government of Haryana, Dr. Sathit Pitutacha, Deputy Minister of Public Health, Thailand, Dr. Sivit Kunkiti, former Deputy Prime Minister, Thailand, colleagues, ladies and gentlemen. It's my great pleasure and privilege to be a part of this important webinar. First of all, I would like to thank the experts and distinguished speakers who joined the event today and share with us their experience in India. As the pandemic of COVID-19 is still ongoing, it is very beneficial to us to learn the important information on crisis management from Haryana experience in coping with Delta variants. Here in Thailand, the Delta variant had taken over the Alpha variant as the dominant strain in the country. The Delta variants had recently been found in almost all provinces in Thailand, including Khon Kaen province. Khon Kaen University is the major university of the northeast of Thailand, where the population size is 1/3 of the country. We are doing our best to promote good health, solve public health problems of the people, and manage the pandemics. KKU Faculty of Medicine and Didaklin Hospital, together with other faculties, hospitals, and healthcare institutes in the region, have worked very hard and played a major role during this COVID-19 pandemics. KKU Medical Hubs strive to provide excellent health services and better access to healthcare in the Northeast Thailand and Greater Mekong sub-region. In addition, the KKU Centers of Excellence, including the Mekong Health Science Research Institute, Emergency Medicine Center, Medical Laboratory Center, and other healthcare related centers, have been rapidly expanded based on a strong foundation of collaboration across KKU, together with national and international health organizations. Currently, KKU has emphasized the utilization of artificial intelligence and robots for the care of and treatment of patients, especially during this COVID-19 pandemics. New medical technologies and innovative tools have been developed for diagnostic and prevent infection, as well as to decrease the risk of close contact among the medical staffs, patients, and the general population. The webinar today has provided vital knowledge and experience from the experts to manage the COVID-19 pandemic in India. It is very beneficial that we learn and share expertise, which will help to improve the pandemic situation in Thailand. We look forward to continuing and strengthening the collaboration between India and Thailand to control the COVID-19 pandemics. With our long-standing experience in healthcare and expanding network with international partners and research institutes, KKU is willing to be the focal point in coordinating with the government of Haryana, the Republic of India, on the management of COVID-19 pandemics. Thank you very much.
Thank you. Thank you, Dr. Chanchai, President of Konkan University. From our side, I thank you, and I would like to thank our eminent participants, Honorable Dr. Suvit, Honorable Dr. Sathit, Honorable Shri Anil Vij, Health and Home Minister of Haryana, Worthy Shri Rajiv Arora, ACS Haryana, Mr. Prabjot Singh, respected Dr. Veena Singh, for encouraging this important knowledge exchange. I would like to thank our expert speakers and panelists for the engaging and critically important webinar today. The pandemic has presented the world with an unprecedented and multifaceted challenge. Knowledge sharing webinars such as ours today are an important part of international coordinated effort to deal with COVID-19. Leveraging expert knowledge across borders will go a long way in helping overcome COVID-19. Thank you, and I will pass first to Dr. Veena Singh for her remarks, and after that, Dr. Suvit for his final remarks. Thank you very much.
Thank you, Dr. Bhardwaj. I would like to share with the entire webinar team that the driving force behind us is our very dynamic Health Minister, Shri Anil Vij, who has so much empathy towards the mankind that it edges on to go to the ground root level and get connected and provide healthcare to the poorest of mankind. Our guiding force, driving light, and encouragement edges all of us to perform even better. I take this opportunity on behalf of the entire health department to thank our worthy Health Minister, Shri Anil Vij, for sparing this time for this purpose despite his very busy schedule. Sir, it is your kindness, your empathy and devotion to every person of this nation which encourages us to move on. Thank you, sir.
Thank you, madam. And I now invite Honorable Dr. Suvit Kunkate to have his final remarks on today's webinar. It was a little bit long, but we are sorry because it is an unending story for COVID, because we have to continue all these things in future also. Please welcome Dr. Suvit Kunkate.
Thank you, Dr. Kupal. But I think that it's not long because the COVID will be with us longer than this. So today we use the time very effective, and I think it's very useful, very informative for us and for both sides. Well, it was in this gripping and most insightful discussion, and that we have over the last 3 hours, almost 4 hours, and I would like to express my sincere thanks and appreciation to Honorable Shri Anil Vij, the Minister of Health and Home of the government of Haryana, India, and Department of Medical Service, Dr. Veena Singh, and the whole team that helping us organizing this, and especially Dr. Gopal, whom I have first contact, and then I learned from him, and I just know that the experience from Haryana will help and be good learning experience for Thailand to cope with this Delta variants. And I'd like to express also my thanks, sincere thanks to my Deputy Minister of Health, Dr. Sathit Pitutacha, my colleague, which I've been working with him for almost 20 years in politics. And he have agreed that to join us and supporting us in this endeavor. And I think that what Dr. Prisha have said, that we also have the open channel, as Dr. Chanchai, director of Khon Kaen University, have said that the Khon Kaen University will be focal point. And as I said, that we keep our channel of communication open, so we can continue and contact and learning from each other. This is just beginning, not the end. So I think this is very important. And I'd like to take this opportunity also to thank our panelists, colleagues, and others from Haryana and also from Thailand for sharing their experience with all of us here. We commend you on your very thoughtful, far-sighted, and effective preparedness to deal with the virus pandemic, and especially what India have already planned for the third wave, that you are expecting that it will be coming soon, and any turn of this virus might take in the future. I'm sure that Thai counterparts would have found your experience worthwhile, and I'm very sure they have several takeaways from your experience, which they are likely to deliberate about as they refine their strategies to deal with the pandemic. I would also very much wish, as I mentioned at the opening remark, and I'd like to mention again, that we keep our channel of communication open, be they virtual as today or physical when travel becomes possible in the coming months. And let today's webinar be a forerunner for a longer term relationship between the professional of Haryana and Thailand. Thank you also to all other participants and organizers from both sides, Indian and Thailand, and whom I could not name them all. They've been working very hard in so short period of time in organizing this webinar. Which is I could say this is the great success that we done in just a few days. So it is especially the rector of Khon Kaen University, whom are the main organizer and coordinator of this very important webinar. The Khon Kaen Medical School and other medical school and so many health professionals. And also I'd like to express my thanks, sincere thanks to Director of Center for Global Challenges at Asian Institute of Technology, whom have looked at these COVID issues. It's a big global challenges for all of us. And this is one of the issues that Asian Institute of Technology with the newly established center could take part in. So, and of course, the Thai PBS, especially Dr. Nattha, which she's not here, but I know that she knows what I'm saying, but for providing a medium to disseminate the deliberations and for her excellent moderation of webinar proceedings. Deep appreciation is also felt by us all here in Thailand for our colleagues from Haryana. So thank you very much, and very much appreciate your efforts and your kind arrangement and organizing and help us to organizing this very successful webinar, especially Excellency who've been with us from beginning. Excellency, the Honorable Sri Anil, which that been with us since the opening until the end of the webinar. I very much appreciate, and I know that your people love you so much, and hope that we continue on this journey. And please stay safe. And thank you very much again. Thank you.
Thank you from our side. And I feel my duty if I also not thank those people who worked hard for this webinar behind the curtains, and our worthy, honorable Health Minister, loving to us, and he is giving all support to us, all confidence to us in tackling this COVID and all other situations.
Yes,
and
the other one.
Thank you.
The other person that I'm sorry, the other person that I should mention, mention, Dr. Dhruva and also Dr. Denpong, the Vice Rector of Khon Kaen University, and Dr. Pirun, whom really been working with me day and night to get this organized. So thank you very much, Dr. Gopal. Sorry for interrupt you.
No, well, I will simply say one word. Honorable Health Minister is an inspiration for all of us. In spite of him suffering so much, sir, from COVID, he had all the complications. Look at his stamina and all that. Thank you so much, Victor, for helping us out and the state, in fact. Dr. Suvithi, he himself had a very bad COVID, and he himself has been a patient, and he has been a pillar of strength for us. Thank you so much, sir.
Thank you. Thank you very much. And please stay safe. Everybody. And then
thank you.
And we'll see you again.
Yeah,
sure.
Bye.
I think Sushila will